Endoskopi ultrasonografi atau EUS adalah tindakan minimal invasif dengan menggunakan alat endoskopi yang dikombinasikan dengan pemeriksaan ultrasonografi. Dengan tindakan ini, kita bisa melihat lebih detail mengenai organ-organ di sekitar abdomen, di sekitar perut, seperti hati, pankreas, kelenjar getah bening, dan dinding saluran cerna lebih detail. Tindakan ini juga bisa dilakukan dengan menggunakan biopsi jarum halus, sehingga dokter bisa mendapatkan sampel cairan atau sampel biopsi atau mengeluarkan cairan dari dinding perut secara minimal invasif. Tindakan ini merupakan salah satu alternatif yang non-invasif dibandingkan tindakan pembedahan secara langsung. Endoskopi ultrasonografi diindikasikan pada kelainan-kelainan di saluran cerna, seperti misalnya kista di pankreas, atau cairan di pankreas, atau tumor di pankreas, atau kelainan di saluran empedu. Misalnya ada kecurigaan ke arah tumor saluran empedu atau batu saluran empedu yang masih meragukan, maka bisa dilakukan tindakan ini. Indikasi lainnya adalah tumor-tumor di saluran cerna yang membutuhkan pemeriksaan lebih detail, keterlibatan lapisan-lapisan saluran cerna. Juga bisa dilakukan tindakan ini.
Selama prosedur, perangkat ultrasound kecil terhubung dengan endoskopi. Endoskopi adalah tabung kecil bercahaya fleksibel dengan kamera terpasang. Dengan memasukkan endoskopi dan kamera ke saluran pencernaan bagian atas atau bawah, dokter dapat memperoleh gambar ultrasonografi organ yang berkualitas tinggi. Karena EUS dapat mendekati organ yang diperiksa, gambar yang diperoleh dengan EUS seringkali lebih akurat dan detail daripada gambar yang diberikan oleh USG tradisional yang harus dilakukan dari luar tubuh. Kapan EUS dilakukan? Pertama, untuk evaluasi stadium kanker. Lalu, untuk evaluasi pankreatitis kronis atau gangguan pankreas lainnya. Kemudian, untuk mempelajari kelainan atau tumor pada organ, termasuk kantong empedu dan hati. Kemudian untuk mempelajari otot-otot rektum bawah dan saluran anus untuk menentukan alasan terjadinya kebocoran usus yang tidak disengaja atau inkontinensia. Dan yang terakhir untuk mempelajari nodul atau benjolan di dinding usus.
Endoskopi ultrasonografi sudah dapat dilakukan di Pusat Endoskopi Saluran Cerna Rumah Sakit Pusat Cipto Mangunkusumo. Alat ini memang masih jarang didapatkan, memang hanya pada center-center besar seperti di RSCM.
At this point, I'd like to introduce you to MiroCam capsule endoscope procedure. Let's connect the receiver. After all of the sensor pads are adhered, raise the patient to a sitting position and connect the data cables to the receiver. Now, I'd like to explain the step when the patient swallows up the capsule. First, tear the capsule packing and take the capsule out while holding the capsule handle. At this moment, check that the LED at the capsule front blinks. Let the patient hold the golden part of the capsule with both hands and check that the capsule and the receiver operate correctly. Allow the patient to swallow the capsule with water. Put the receiver in the receiver bag. Help the patient to wear it in a way that allows him or her to move around comfortably. Place the data cables in the cable bag neatly as to not become tangled. When all of the steps are done, advise the patient of the following precautions during the capsule endoscopy.
Millions of people, adults as well as young children and babies, suffer from heartburn and regurgitation caused by the reflux of gastric contents into the esophagus. We're talking about gastroesophageal reflux disease, generally abbreviated as GERD. It can sometimes be difficult to know whether symptoms are due to GERD or something else. A 24-hour impedance pH examination with the Omega recorder can be very useful to diagnose this problem. To understand what we are talking about, you first have to pick up some in-depth information about pH measurement, impedance measurement, and reflux monitoring.
This is then followed by inserting a different probe which measures the pH and impedance. Unlike the first probe, this one is left in place for 24 hours straight. During this period of 24 hours, the probe looks for any evidence of reflux and records what time, how long, what pH, and how high up the reflux reaches. All this information is automatically recorded onto a computer as shown here. After instruction is provided, the patient is allowed to go home or back to work.
Welcome to this movie on high-resolution esophageal manometry. We will show you how easy the examination is with the Solar GI HRM system of MMS. You are now ready to welcome the patient. You can apply some lubricating gel to ease the passage of the catheter. Gently insert the catheter into the pharynx. Instruct the patient to bring his head forward to swallow the catheter. Let the patient take small sips of water. This will ease the process. Position the catheter. Verify the landmarks of the upper and lower sphincter on the screen. To summarize, with HRM, you can simplify and shorten the esophageal manometry examination. Thanks to MMS, the HRM examination is really simple.
The Hydrogenius is a breath analysis monitor that can help you find the cause of your gut discomfort, such as flatulence, bloating, and nausea. A breath test with a Hydrogenius is quick, easy, and most importantly, non-invasive. It works by measuring the level of hydrogen on your breath that is produced when your gut breaks down food. Based on the levels of these gases, it can help to determine if you have a condition such as a food intolerance, malabsorption, or a bacterial overgrowth problem. To take a breath test with the mouthpiece, attach the D-piece to the Hydrogenius and press the breath test icon to begin. You'll be asked to inhale and hold your breath for 15 seconds before slowly exhaling into the Hydrogenius. The reading will rise and stabilize on screen. When the test is finished, you can either choose to take another test, save the reading to a patient's profile, or return to the home screen. Readings and results can be interpreted using the interpretation wheel included with the Hydrogenius.
Baik, terima kasih atas kesempatan yang diberikan kepada kami pada siang hari ini. Sekilas saja, berikut adalah portofolio produk PT Combiphar di bidang gastroenterologi dan hepatologi. Kami memiliki somatostatin Leomark yang mengandung 3 mg somatostatin per ampulnya yang dapat digunakan untuk kasus-kasus pendarahan atau bleeding baik pada tukak lambung, tukak duodenum maupun pada varices esophageal. Somatostatin kami ini juga sudah masuk ke dalam e-katalog sehingga dapat digunakan untuk pasien-pasien dokter yang BPJS. Untuk kasus-kasus hepatic encephalopathy, kami memiliki Hepamers yang mengandung L-ornithin L-aspartat. Hepamers tersedia dalam 2 bentuk sediaan, yaitu Hepamers infusion yang diberikan secara parenteral dan Hepamers granulat yang diberikan secara oral. Hepamers infusion mengandung 5 gram lola per ampulnya, sedangkan Hepamers granulat mengandung 3 gram lola per sasetnya. Berikut adalah kriteria W7 untuk hepatic encephalopathy beserta dengan rekomendasi dosisnya. Untuk hepatic encephalopathy grade 1 dan grade 2, Hepamers infusion dapat diberikan dengan cara melarutkan 4 ampul Hepamers infusion ke dalam 250 ml larutan steril, kemudian didrip selama 4 jam. Untuk hepatic encephalopathy grade 3 dan grade 4, dapat diberikan hingga maksimal 8 ampul Hepamers infusion yang dilarutkan ke dalam 500 ml larutan steril dan didrip selama 8 jam, sehingga tercapai dosis maksimal 40 gram lola per harinya. Sementara untuk Hepamers granul, dapat diberikan 3 kali sehari, 1-2 saset. Selanjutnya, kami memiliki Protexin, yaitu suatu simbiotik yang mengandung 7 strain bakteri untuk probiotiknya, yang dilengkapi juga dengan FOS sebagai prebiotiknya. Lalu kami juga memiliki Constipen yang mengandung laktulose, yang dapat digunakan untuk kasus-kasus konstipasi maupun portal systemic encephalopathy. Selanjutnya, kami memiliki Fleet Enema, suatu laksatif yang diberikan melalui rektal dan bekerja secara cepat untuk kasus-kasus emergensi, dilengkapi dengan aplikator yang lembut sehingga nyaman untuk pasien. Fleet Enema juga sudah masuk ke dalam e-katalog sehingga dapat digunakan untuk pasien-pasien BPJS. Selanjutnya, kami juga memiliki Fosfosoda, suatu laksatif oral dengan rasa ginger lemon yang segar. Fosfosoda sudah terlisted atau sudah masuk ke dalam e-katalog sehingga dapat diresepkan untuk pasien-pasien dokter yang BPJS. Demikianlah portofolio produk PT Combiphar di bidang gastroenterologi dan hepatologi. Kami berharap produk-produk kami dapat membantu meningkatkan outcome terapi dari pasien-pasien yang sedang dokter tangani saat ini. Terima kasih atas perhatian dan kesempatan yang diberikan kepada kami.
As healthcare professionals, we understand the need for your continuing medical education each year. Furthermore, the pandemic and travel restrictions have made it difficult to attend congresses, both locally and globally. Brainmaster is a platform for healthcare professionals who need access to fast, effective, and convenient information regarding psychiatry and neurology through a series of webinar events suited to your needs. Simply browse and select your country on Brainmaster to pre-register for upcoming webinars, or even choose from recorded webinars to watch on your own time. And some of these webinars are also CME accredited. Now, you don't have to worry about physically attending meetings and Congress to get the valuable medical information and education you need. To access, log on to sea.progress.im and click on the Brainmaster banner, or visit cmesea.com to select the webinars available for you. Brainmaster, your one-stop center for webinars around the world.
Endoskopi ultrasonografi atau EUS adalah tindakan minimal invasif dengan menggunakan alat endoskopi yang dikombinasikan dengan pemeriksaan ultrasonografi. Dengan tindakan ini, kita bisa melihat lebih detail mengenai organ-organ di sekitar abdomen, di sekitar perut, seperti hati, pankreas, kelenjar getah bening, dan dinding saluran cerna lebih detail. Tindakan ini juga bisa dilakukan dengan menggunakan biopsi jarum halus, sehingga dokter bisa mendapatkan sampel cairan atau sampel biopsi atau mengeluarkan cairan dari dinding perut secara minimal invasif. Tindakan ini merupakan salah satu alternatif yang non-invasif dibandingkan tindakan pembedahan secara langsung. Endoskopi ultrasonografi diindikasikan pada kelainan-kelainan di saluran cerna, seperti misalnya kista di pankreas, atau cairan di pankreas, atau tumor di pankreas, atau kelainan di saluran empedu. Misalnya ada kecurigaan ke arah tumor saluran empedu atau batu saluran empedu yang masih meragukan, maka bisa dilakukan tindakan ini. Indikasi lainnya adalah tumor-tumor di saluran cerna yang membutuhkan pemeriksaan lebih detail, keterlibatan lapisan-lapisan saluran cerna. Juga bisa dilakukan tindakan ini.
Selama prosedur, perangkat ultrasound kecil terhubung dengan endoskopi. Endoskopi adalah tabung kecil bercahaya fleksibel dengan kamera terpasang. Dengan memasukkan endoskopi dan kamera ke saluran pencernaan bagian atas atau bawah, dokter dapat memperoleh gambar ultrasonografi organ yang berkualitas tinggi. Karena EUS dapat mendekati organ yang diperiksa, gambar yang diperoleh dengan EUS seringkali lebih akurat dan detail daripada gambar yang diberikan oleh USG tradisional yang harus dilakukan dari luar tubuh. Kapan EUS dilakukan? Pertama, untuk evaluasi stadium kanker. Lalu, untuk evaluasi pankreatitis kronis atau gangguan pankreas lainnya. Kemudian, untuk mempelajari kelainan atau tumor pada organ, termasuk kantong empedu dan hati. Kemudian, untuk mempelajari otot-otot rektum bawah dan saluran anus untuk menentukan alasan terjadinya kebocoran usus yang tidak disengaja atau inkontinensia. Dan yang terakhir, untuk mempelajari nodul atau benjolan di dinding usus.
Endoskopi ultrasonografi sudah dapat dilakukan di Pusat Endoskopi Saluran Cerna Rumah Sakit Pusat Cipto Mangunkusumo. Alat ini memang masih jarang didapatkan, memang hanya pada center-center besar seperti di RSCM.
At this point, I'd like to introduce you to Mirocam capsule endoscope procedure. Let's connect the receiver. After all of the sensor pads are adhered, raise the patient to a sitting position and connect the data cables to the receiver. Now, I'd like to explain the step when the patient swallows up the capsule. First, tear the capsule packing and take the capsule out while holding the capsule handle. At this moment, check that the LED at the capsule front blinks. Let the patient hold the golden part of the capsule with both hands and check that the capsule and the receiver operate correctly. Allow the patient to swallow the capsule with water. Put the receiver in the receiver bag. Help the patient to wear it in a way that allows him or her to move around comfortably. Place the data cables in the cable bag neatly as to not become tangled. When all of the steps are done, advise the patient of the following precautions during the capsule endoscopy.
Millions of people, adults as well as young children and babies, suffer from heartburn and regurgitation caused by the reflux of gastric contents into the esophagus. We're talking about gastroesophageal reflux disease, generally abbreviated as GERD. It can sometimes be difficult to know whether symptoms are due to GERD or something else. A 24-hour impedance pH examination with the omega recorder can be very useful to diagnose this problem. To understand what we are talking about, you first have to pick up some in-depth information about pH measurement, impedance measurement, and reflux monitoring.
This is then followed by inserting a different probe which measures the pH and impedance. Unlike the first probe, this one is left in place for 24 hours straight. During this period of 24 hours, the probe looks for any evidence of reflux and records what time, how long, what pH, and how high up the reflux reaches. All this information is automatically recorded onto a computer as shown here. After instruction is provided, the patient is allowed to go home or back to work.
Welcome to this movie on high-resolution esophageal manometry. We will show you how easy the examination is with the Solar GI HRM system of MMS. You are now ready to welcome the patient. You can apply some lubricating gel to ease the passage of the catheter. Gently insert the catheter into the pharynx. Instruct the patient to bring his head forward to swallow the catheter. Let the patient take small sips of water. This will ease the process. Position the catheter. Verify the landmarks of the upper and lower sphincter on the screen. To summarize, with HRM, you can simplify and shorten the esophageal manometry examination. Thanks to MMS, the HRM examination is really simple.
The Hydrogenius is a breath analysis monitor that can help you find the cause of your gut discomfort, such as flatulence, bloating, and nausea. A breath test with a Hydrogenius is quick, easy, and most importantly, non-invasive. It works by measuring the level of hydrogen on your breath that is produced when your gut breaks down food. Based on the levels of these gases, it can help to determine if you have a condition such as a food intolerance, malabsorption, or a bacterial overgrowth problem. To take a breath test with the mouthpiece, attach the D-piece to the Hydrogenius and press the breath test icon to begin. You'll be asked to inhale and hold your breath for 15 seconds before slowly exhaling into the Hydrogenius. The reading will rise and stabilize on screen. When the test is finished, you can either choose to take another test, save the reading to a patient's profile, or return to the home screen. Readings and results can be interpreted using the interpretation wheel included with the Hydrogenius.
Halo. Halo. Tes.
Sudah terdengar, Dr. Firly?
Oh, oke, baik. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning to all professors, doctors, and colleagues. Welcome again to Virtual Jakarta International GI Endoscopy Symposium 2021. Hello. First of all, we thank to Almighty God for all the blessings to us, and we are very happy to welcome you again today to this virtual congress. Hello.
Iya, silakan dilanjut, Dr. Firly.
The sound is clear, Dr. Firly.
Oh, okay, thank you. And then we hope that we will give you the best and insightful experience of Congress today. Continuing the previous batch, for right now, we will have one plenary lecture and 2 symposium. And then now, without further ado, let's begin the program for today. Hello. The first agenda is plenary lecture 6 with the topic Recent Indication and Innovation of Capsule Endoscopy Examination, sponsored by Danatech. For this plenary, it will be moderated by Professor Dadang Makmun, MD PhD, from the Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo National General Hospital, Jakarta, Indonesia. So to Professor Dadang Makmun, please, you may lead this plenary lecture.
Thank you, Dr. Firly, for opening this session today. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Our professors, our college, ladies and gentlemen, this morning we are going to have an important lecture that will be delivered by Professor Abdul Aziz Rani with the topic of recreations and innovations of capsule endoscopy examination. I think I have not to introduce Prof. Aziz because we have already know he is our teacher, our sensei, and our patron, especially in our university. Prof. Aziz, the time is yours. The lecture will be delivered within 30 minutes. Please.
Thank you very much. Is the voice is clear? Is okay? The voice is clear?
Yes, Prof.
Yes, Prof.
Yes.
The voice
Okay,
is
thank
clear.
you
We
very
can
much.
hear you clearly, Prof.
Okay, very sorry I asked you. So I will talk about the indication and innovation of endoscopy examination. This is a very useful and very well-developed diagnostic modality in gastrointestinal endoscopy.
Volume.
Can you see my slides? Hello?
Not yet, Prof.
Not yet.
Not yet.
Okay,
Yes,
I will
Prof.
share the screen first.
Okay, Prof.
Yeah. Slide view.
Okay.
It's okay now? Okay, sorry for the trouble. Okay, so we'll proceed further.
Yeah.
So I think we'll talk a little bit in general about capsule endoscopy that already well known by all of us. So I just remind you some maybe the latest development and innovation. It's already 50 years since 2001 when FDA approved capsule endoscopy, and nowadays nowadays in our country, also there are a lot of examinations. For example, more than 500,000 cases in the last 5 years. So this modality has a higher diagnostic yield compared to push endoscopy at the time. So far, capsule endoscopy is now the first examination For example, to perform after upper and lower endoscopy for occlusive bleeding. This is several type of capsule endoscopy from Pilcam, Olympus, and also I think our sponsor is capsule endoscopy is Miracam. So basically, inside the capsule, there are optical lens and also illuminating lights, and also some power battery, and also for transmission of the image to the receiver. So basically, this is the compound of capsule endoscopy. And also workstation is very important. This is very, very time consuming work for the physician. So we need some development in this area of workstation. Again, this is the anatomy of capsule endoscopy. So we have transmitters and also antenna to transmit the image to the receiver. If we compare several capsule endoscopy, from Pelcam there is Medtronic, Myrocam Intromedic, and from Olympus Endocapsule, and from OMOM. You see that the dimension is almost the same, the weight also almost the same. The difference is the degree of field of view between 140 degree to 170 in Myrocam capsule. There are several modality of transmission. I think all of this transmission system is quite effective. The battery is very important to have a complete small bowel examination. And you see that the battery life is 10 to 11 hours. It is enough to complete the whole small bowel observation. This is the picture. You already well known about the all the component. I've already told you about the workstation. This is the part of the work of the physician, also supported by our technician. There are some modification for real-time capsule endoscopy, endocapsule. So this real-time capsule endoscopy has completed in 70.5% and 94.4%. So this system can help the physician to check real-time about the position and the image of the capsule. The company and also the scientists already developed several specific organ-specific capsule endoscopy. There is esophageal capsule, not very interesting for endoscopies because very easy for us to check esophagus. Small bowel might be one of the best utilization of capsule endoscopy. And further colon capsule endoscopy with technological development can help the doctors and also to help the colon cancer screening in the community. This is again the new capsule organ specific esophagus and colon. We can see for esophagus and colon the camera is dual camera, and the frame is slower because they have to observe a larger lumen of the colon, for example, and the duration is also similar. There is also special function capsule, a self-disintegrating capsule, a gel capsule, just to make sure that there is no obstruction. And if there is obstruction, this capsule is self-disintegrating, so it is not necessary to do surgical intervention. So it is very important to make sure if we are worried about the suspect of intestinal structure. The working mechanism of capsule is propelled by nature peristaltic, so depend on the peristalsis of the GI tract, and there is some variation in intestinal transit time. So about 25% capsule cannot reach the cecum within the limited battery. So it is not complete examination. The other functional problem is if there is some delay in esophageal and gastric transit time. So to overcome this limitation, you can add prokinetic drugs or give some bowel preparation agent to speed up gastric and small bowel transit time. Sometimes it is delayed a little bit. This is the standard preparation, fasting 12 hours. You can give polyethylene glycol, 1 liters. Maybe in every hospital they have a standard preparation for this capsule endoscopy, but this preparation is very important to have a clear picture, the clear image of the small endoscopy. When the patient can have a meal, when already swallow the capsule, maybe after 4 hours you can resume the meal because maybe the capsule already passed through the small bowel. Just give maybe very liquid meals. For real-time capsule endoscopy, for this real-time endoscopy should be checked every 50 minutes to make sure that the capsule already inside the small bowel. If it is filled, then we can add, for example, prokinetic like erythromycin. But the problem is erythromycin may impair the image quality, so it is not very recommended. This is, in summary, the preparation. You can add also antifomic, for example, and this is the result. The well-prepared is very clean, no residual in the lumen, and the poorly prepared, you can see there's still rest of food or liquid food in the small bowel lumen. We have a scale for quality assessment according to NIF. If there is no intraluminal fluid in the lumen, the scale is 2. If the scale is 0, it means that the preparation is not good. After the result of the capsule endoscopy, the imaging should be interpreted by a doctor or by a technician. There is some tips from the European Society of Gastrointestinal Endoscopy, 2018, that should be slowly. The optimal reading speed is 10 frames per second in single vision mode, or up to 20 frames per second if you have a dual or quadruple modes. So please slowly. So it is very important also to reduce the reading speed in the proximal small bowel, because at this segment it is faster. So you must be very carefully not to miss a deletion in this area. Just to show you that mostly the detection rate of ampulla by capsule endoscopy is very low. For example, papilla flutteri, very easy to check by endoscopy, but for capsule endoscopy, only seen in about 10% of small bowel capsule endoscopy. So be careful to check. So in clinical practice, of course, we have first to do clinical assessment to establish the clinical diagnosis and the aim of capsule endoscopy examination. So upper and lower endoscopy, it is very standard to do before capsule endoscopy, including esophagogastroduodenoscopy, proctoscopy in some case, and also ileocolonoscopy. It is a common practice. So after we establish indication and following the algorithm of the guideline, we can do capsule endoscopy. And also the timing. For example, there is a recommendation that video capsule endoscopy should be performed after the bleeding episode, optimally within 2 weeks. There is some indication, clinical indication for capsule endoscopy. I already told you the small bowel bleeding, the possibility of polyps or small bowel tumors, NSA enteropathy, small bowel Crohn disease. This is very, very critical, and also very, there are some difficulties to have this indication, and also for celiac diseases. It is not very common, but we should know about celiac diseases because this is very common for Western people. First one, the obscure gastrointestinal bleeding. This is the most frequent indication for small bowel. The yield of VCE in obscure GI bleeding higher if the bleeding is still ongoing compared to obscure and occult bleeding. The diagnostic yield is better if it is performed within 48 hours of patient hospitalization. From Mayo Clinic showed that the yield of FCC in overt group is 60% higher than obscure occult group. As the result, as overall result, showing that VCE was significantly reduced hospitalization, additional investigation, and also already measured the number of units of blood transfusion compared before using video capsule endoscopy. Small bowel tumor is not very frequent finding in the small bowel, but after application of capsule endoscopy, it was shown that the prevalence is higher, is not 2%, but ranging up to almost 10% in patients who underwent capsule endoscopy. Usually, the indication for the small bowel tumor is if there is obscure gastrointestinal bleeding. The majority of tumor by capsule endoscopy, adenocarcinoma, carcinoid, lymphoma, sarcoma, and hematoma. Also, maybe some in some patients with gastrointestinal tumor. This is very tricky about small bowel Crohn disease because there is a risk of stricture. So the main reason for capsule endoscopy in Crohn is to establish the diagnosis, assess the prognosis, measure the disease activity, mucosal healing, so endoscopic mucosal healing, and also to define the extent and severity of the disease. There is some study showing that in prospective study, capsule endoscopy is more sensitive compared to computed tomography, ileocolonoscopy, or even small bowel FLOW. The risk of retention due to strictures is about 5 to 7%. So please be careful. Please be carefully. You have to check the risk of stricture before applying the capsule endoscopy. In clinical practice, because the specificity is low, maybe it's necessary to do preceding radiography to avoid the risk of retention. Celiac disease is also very important. There are many patients with celiac disease, and in this case, maybe it could be useful to make a diagnosis. And in suspected celiac disease, we can see using the duodenal histology as a gold standard. Those studies show that has a sensitivity almost 90% and specificity almost 100%. For patients with celiac without treatment, untreated patient, compared with biopsy, it was shown that capsule endoscopy had 92% sensitivity and 100% specificity. So this is a very accurate diagnosis, imaging diagnosis by capsule endoscopy for patients with celiac disease. Just to give you some image, this is from literature. You see that the bleeding in the ileum is very clear. There's some blood on the surface, and for celiac disease, the picture showed that there is villus blunting, and it causes scallop mucosa. So what I can see that there is irregularity in the mucosa of the small bowel. This is show you the inflammatory bowel disease, Crohn disease in small bowel. You can see that there is edematous villi and erythematous small bowel mucosa around the stenosis. In Crohn, it is very common. The complication is stricture or stenosis of the lumen. And on the right panel, you can see stricture due to non-steroidal NSAID, showing a smooth muscle, narrowing lumen, a little bit deformity, not clear lumen, and there is inflammation reaction around the strictures. So it is very useful for diagnosis of NSAID small bowel enteropathy. Again, this is celiac disease. There is a scallop duodenal fold. This is in duodenum. Then you can further make biopsy to make sure the villus atrophy in this patient with celiac disease. This is the algorithm by the European Society of Gastrointestinal Endoscopy. Again, we can see that video capsule endoscopy could be the first-line treatment for patients with occult or overt obscure GI bleeding. So if it is positive, we have to further examine the patient with minimal invasive examination like device-assisted endoscopy, double balloon or single balloon to make biopsy, and also in some cases can do for treatment. This is algorithm recommended by European Society of Gastrointestinal Endoscopy 2015. Again, colon capsule endoscopy, newly developed the colon capsule endoscopy and number 2 with a very high resolution image. You can see the small polyps, very small one polyps, and also this capsule endoscopy can show the image of angioectasia under white light. You can see in the panel B and C. And this is a very interesting improvement for enhanced imaging using flexible spectral imaging color enhancement, twice from the Fuji color. You can see a very clear image of this angioectasia. Maybe it's better if twice also used together with blue light application. So for colon cancer, for colon capsule endoscopy number 2, if we compare with colonoscopy for detection of colon polyp, it was shown that the completion of colon capsule is around 80 to 90%. For the polyp bigger than 6 millimeter, the sensitivity is between 82 to 89%, specificity around 70%. And if it is bigger, of course, the sensitivity and specificity is higher. So it must be a very useful, especially for patients that cannot afford the colonoscopy because the morbidity or something like that. This is just to show you the current status of video capsule endoscopy and deep enteroscopy. Both this modality is complementary. So diagnostic first maybe by capsule, followed by further endoscopic diagnostic modality to make biopsy or to do some treatment for hemostasis, for example. This is enteroscopy development. We know the single balloon, double balloon, spiral, and also it is now more safe of using the CO2 gas for enteroscopy. The development of video capsule endoscopy, the latest development, is to have a greater field of view, for example, 360 degree, and also to manipulate the movement of the capsule in the lumen using magnetic guided capsule, MGCE. And this is just to show you the comparison between capsule and double balloon. I think both are complementary. So to make a short summary, so small bowel video capsule endoscopy, the completion rate is about 80%. The diagnostic yield 30 to 50%, and this result can change the clinical management up to 60% of the patient for the detection and localization of Sclerotia bleeding. In Crohn's disease, also there's some study. It was shown that double balloon endoscopy and other deep endoscopy technique is not considered first-line tool, but may be useful for histologic confirmation of small bowel finding on capsule endoscopy. Limitation and further development for capsule endoscopy, we realize that the limitation is inability to localize the detected lesion, and there is no mechanism to control capsule movement, but now we have a magnetic guided capsule endoscopy, but at least it is not all the small bowel mucosa will be visualized. So the near future development is to have a better resolution up to 360 degree, wider angle, longer battery life to accomplish the examination, and a real-time external image maybe can help the reader to watch the image being captured during the procedures. So the other part of capsule endoscopy is the workstation. The workstation is very, it's very time consuming, takes several hours maybe. So doctors don't like this kind of work, so maybe they leave it to the technician. So be careful, sometimes it misses the diagnosis. So there is development for a software enhancement, which can help and identify the specific lesion. For example, the suspected blood indicator, SBI, quick view for fast viewing automation, and also enhancement of of the characteristic of the lesion using VICE. I already showed the picture. So three-dimensional representation tool can also help to make a higher yield of diagnostic. But the latest development is the new evidence of artificial intelligence and deep learning, which promises the capsule reading. So deep learning algorithm had been developed for identifying with high sensitivity and accuracy for organ of origin, motility, active bleeding, celiac disease, and other small lesion in the small bowel. So just to stimulate our concept about diagnostic in imaging, so developing of machine learning is developing of any technique that enable computers to mimic cognitive function displayed by human. So the function, the higher function level is learning and problem solving. So it is not necessary every time to give the software or for the computer. Machine learning is a subset of artificial intelligence. Then by using this system, computer can continue to learn based on information or experience already learned. So it is very important for the very high burden of image like capsule endoscopy, maybe thousands of images that should be checked by the doctors. So with machine learning, more complex function can develop, and tasks can be developed such an algorithm for self-driving cars and flying of drones. So gastroenterologists should be follow the advancement of information technology that already very common in the community. The advanced machine learning convolutional neural network is very common use because it is very effective for image classification tests. So this machine learning model is already used in capsule endoscopy. So CNN learn how to detect the element of interest more accurately. She can make inferences and also can make interpretation. This is the diagram. There are several layers of algorithm to check, for example, the polyp. At the end, this artificial intelligence application can give more accurate polyp detection rate. So maybe in the next future, you can have a study to compare artificial intelligence with polyp detection rate, for example, in PSG in Cipto Mangunkusumo. I think it's a good chance because what I know that in Faculty of Computer Science, University of Indonesia, they already apply this artificial intelligence for the diagnosis, histopathology diagnosis. You can check the study because it is already published. So gastroenterology should follow the pathology. Yeah, this is some study concerning the artificial intelligence clinical study for capsule endoscopy in small bowel. You can see the detection rate is about 90%, highly specific, highly sensitive. So it is I think it is very promising. This is also just to show you, for example, a study by Louis using 439 capsule video to create a CNN. The accuracy is 97%. So can identify many lesions in the small bowel. The accuracy is 98% for location identification and can develop higher sensitivity. This is a study by Dr. Ding in China in 2019. You see that the number of images is 113 million images from thousands of patients. So they can pick about 4,000 lesions of interest and identify with this model, CNN model, convolutional neural network, with 90.88% sensitivity, compared to 74.57% by sensitivity by gastroenterologists. So gastroenterology will be, I think, very much helped by this kind of system. And what is also important, the time, reading time, mean reading time is only 6 minutes, less than 6 minutes compared with 96.6 minutes by the traditional method. This is very promising. So to conclude about the capsule endoscopy, I think we know since 50 years ago, capsule endoscopy has already opened the last frontier of gastrointestinal tract, the small bowel. Diagnostic accuracy is about 36% to 90%. And for other clinical indication, it is very helpful for the changing development of the patient. For diagnosis and the possibility of treatment, capsule endoscopy as the first screening tool, followed by device-assisted endoscopy, small bowel endoscopy, double balloon or small bowel for tissue diagnosis. And the latest development is artificial intelligence in video capsule endoscopy can analyze millions of images with sensitivity almost 100% compared to 74.57% sensitivity by gastroenterology. And also the mean time, 6 minutes compared to 96.6 minutes. So if we look in the horizon, the far horizon of this development of capsule endoscopy, I think there's already study, maybe animal study, using capsule endoscopy to not only biopsy, but also for treatment, epinephrine injection, tattooing, and also capsule ultrasound, argon plasma coagulation, and heat probe application. So the horizon is open for you to improve and develop. And I hope for you, because I'm old, I can say that the younger generation should be become a leader, not only the follower. Yeah, please, thank you. Thank you very much for your attention.
Thank you, Professor Aziz Rani, for your very clear and interesting and also important lecture for us. We have learned from you about video capsule endoscopy and what is the development since the beginning until right now. And then we can take the advantages of this modality to improve our health services, especially in the field of gastroenterology. So thank you very much, Prof. Aziz. And then I return back this session to Dr. Firly. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh. Thank you once again to Professor Abdul Aziz Rani and also Professor Dedak Mahmoud as a moderator. We will take a hello. Hello.
Yeah.
Ya, silakan Dr. Firly.
Hello. Can you hear me?
Yes, we are ready.
Okay. Thank you once again to Professor Abdul Aziz Rani and Professor Dedang Makmun for insightful. Professor Aziz Rani, Professor Aziz, you may turn on your camera.
Yeah.
Yeah, okay.
Okay. I will count. One, two, three. Okay, thank you very much.
Thank you.
And also thank you to Danatech as our sponsors. Now the second 9 with the topic Gastrointestinal Diseases, sponsored single topic by Combivar. For this symposium, it will be moderated by Dr. Fuad Bakri from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Sriwijaya, Muhammad Hussein General Hospital. Please, you may lead this symposium.
Okay. Good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
We
wabarakatuh.
continue our program. This is for the symposium number 9. Thanks for the first. I want to thank for the organizing committee to entrust me to be a moderator in symposium. This symposium we have 3 speakers. Is the number 1 is the Dr. Kaka. Penalty will be presented by the title is pancreatitis post ERCP, rule the somatostatin, and number 2 is to be presented by the agitator Prof. Murdani, Murdani, and number 3 will be presented by Dr. Cahyadi. I think we are to our professor or esteemed and the expert, we are directed to Dr. Kaka. Please, you presented and you have 25 minutes. Please, Dr. Kaka.
Thank you, Dr. Fuad, for the nice introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. I will talk about the post-ERCP pancreatitis, the role of somatostatin. This is the outline of my presentation that I will talk about. The first is the definition. According to the newest ESG guideline, post-ERCP pancreatitis or PEP can be diagnosed when the patient experiences new or worsened abdominal pain accompanied by more than 3 times normal value of amylase or lipase at more than 24 hours after ERCP, which requires admission or prolongation of planned admission. ERCP can cause a lot of complications such as bleeding, perforation, cholecystitis, cholangitis, and sedation-related adverse events. However, among all post-ERCP pancreatitis is the most common complication. The incidence is around 3.5 until 9.7%, and the mortality rate is about 0.1 until 0.7%. Most cases are mild. For classification of severity, we still use the revised Atlanta classification. We classified it as mild when there are no organ failure and local or systemic complications. We classified it as moderate when there is transient organ failure or local or systemic complication without persistent organ failure. Severe is defined as persistent organ failure. PEP has different characteristics than non-ERCP acute pancreatitis. First, it is associated with increased rates of developing infected necrosis and postoperative pancreatic or enteric fistula. It also tends to occur in younger cohorts. However, PEP is associated with lower mortality rate because most cases are mild. Despite that, it does increase the length of hospitalization. How can we identify whether a patient has low risk or how high risk of developing PEP? ESGE classified the risk factors into definite and likely risk factors. Each classification has patient-related or procedure-related risk factors. Patients are considered to be high risk of PEP when they have at least one definite or two likely risk factors. The definite risk factors include patient-related factors such as suspected sphincter of OD dysfunction, female sex, previous history of pancreatitis, or PEP. Definite procedure-related risk factors include difficult cannulation, pancreatic guide wire passages more than once, and pancreatic injection. Patient-related likely risk factors include younger age, non-dilated extrahepatic bile duct, absence of chronic pancreatitis, normal serum bilirubin, and presence of end-stage renal disease. Procedure-related likely risk factors include procedures such as pre-cut sphincterotomy, pancreatic sphincterotomy, biliary balloon sphincter dilation, failure to clear bile duct stones, and interductal ultrasound. There are several theories regarding the pathogenesis of PEP, and it is multifactorial. Cannulation can cause trauma to the papilla, which causes spasm of the sphincter of OD and edema of the papilla, leading to the obstruction of the flow of pancreatic juice, and the end result is inflammation. Injection of contrast media during procedure also cause injury to the epithelial and acinar cells due to pressure. The osmolarity and the ionic nature of the contrast itself is also believed to play a role. ERCP maneuvers can also cause reflux of intestinal enzyme. Bacteria is also believed to be a factor where they can produce enzymes or toxins that can produce cytokines causing cellular damage. Whatever the inciting factors are, they all result in premature intracellular activation of pancreatic proteolytic enzyme, causing autodigestion and inflammation, leading to pancreatitis. Therefore, agents and strategies to prevent PEP are made to target the possible pathogenesis. For example, somatostatin can reduce pancreatic secretion, which leads to several trials investigating its effect. NSAID, which is already an established strategy, acts on the inflammatory process. By understanding the pathogenesis, we can try new agents and combine several agents which target different pathogenesis pathways. Next, a brief overview of somatostatin. It is actually originally discovered accidentally in the hypothalamus of rats as a peptide inhibiting the release of growth hormone, hence the name of somatostatin. However, scientists soon discovered that somatostatin can inhibit various physiological functions, such as pituitary, pancreatic, and GI hormone secretion. To exert its actions, somatostatin binds to specific somatostatin receptor in the cells. The human somatostatin, though, has several disadvantages when it is used for therapy, such as the need of IV infusion, multiple different effects in different organs, short half-life, and the phenomenon of post-infusion hormone hypersecretion. To mitigate these disadvantages, octreotide was created, which is the first somatostatin analog synthesized. Octreotide has been used in various diseases, such as GI bleeding. In theory, octreotide has better pharmacokinetics profile than somatostatin. However, this has not been the case for PAP prophylaxis, as well as we will discuss later. Lanreotide is another somatostatin analog with similar pharmacokinetic profile to octreotide. In the GI system, somatostatin also plays an inhibitory role such as reducing blood flow, slowing contraction, and decreasing secretions, including pancreatic exocrine function. This inhibitory effect of pancreas by somatostatin had been shown in several trials. This is a trial of 12 healthy volunteers who were first given secretin and cerulane to stimulate the pancreas. Stimulation of pancreas caused increased amino acid uptake by the pancreas, and this was reflected by decreased free plasma amino acid level. Then the same subjects were given somatostatin. After somatostatin administration, there was an increase in free plasma amino acid level, as shown in the graph. which meant that there was a decrease in the activity of the pancreas. Increasing the dose of somatostatin also decreased the pancreas activity further. Thus, from this trial, we can see that somatostatin can decrease the secretion of pancreatic enzymes. Somatostatin may also have an anti-inflammatory properties. This is a study that investigated the effect of somatostatin analogs on the inflammatory reaction in vivo. Somatostatin was given to rats which had carrageenan-induced inflammation. From the bar chart, we can see that the volume of the exudate on the left chart were lower in rats given somatostatin than the control groups. The second bar chart showed that the concentration of the exudate decreased in the somatostatin group than the control group, and it was dose dependent. The level of pro-inflammatory cytokines such as TNF-alpha also decreased in the somatostatin group. Therefore, this trial showed that somatostatin might be useful to control inflammation such as in pancreatitis. This is another study that investigates the effect of somatostatin administration on the apoptosis of pancreatic acinar cell and expression of pro-apoptotic genes such as BAX in the treatment of acute pancreatitis in mice. The idea is that if the apoptotic index increases, there is a reduction of the pancreatic inflammation, as shown in the bar chart. The somatostatin group had higher apoptotic index than the control group. There was also an increase in the BAX expression, which showed decreased inflammation. There are also several trials investigating the effect of somatostatin administration on the sphincter of OD in patients with pancreatitis. The results, however, were still controversial. This is one such study where somatostatin was given to a small number of patients with alcoholic and idiopathic pancreatitis, and manometry of sphincter of OD was performed at baseline and after somatostatin infusion. As shown in the line chart, 13 out of 14 patients had decreased mean pressure after somatostatin infusion, which might improve the flow of pancreatic juice. However, there was also other studies which showed that somatostatin increased sphincter of OD pressure instead. Octreotide administration also demonstrated increased sphincter of OD contraction after administration. Therefore, further studies are still needed. Based on the physiological effects of somatostatin discussed previously, a lot of trials have been assigned to investigate the utility of somatostatin in the prevention of PEP. This slide showed a multicenter open-label RCT involving 550 patients. Patients were randomized into two groups, where one group received a combination of diclofenac and somatostatin, while the other group were given only placebo. The somatostatin regimen used is somatostatin 250 microgram per hour infusion for 6 hours, and the outcome investigated were incidence of PEP and hyperamylasemia. The result of this study showed that the incidence of PEP was significantly lower in the treatment group compared with the placebo group, 4.71% versus 10.38%. And this difference increased in subgroup of high-risk patients. Multivariate analysis also showed that the absence of combination therapy was independently associated with PEP. The limitation of this study, however, is that patients also receive diclofenac aside from somatostatin. So it is hard to tell whether the reduction of PEP is caused by diclofenac alone, somatostatin alone, or both. This is also another multicenter open-label RCT involving a large number of patients. This time, however, the patients were randomized into somatostatin group or control group, which received routine treatment. The somatostatin dose, however, is a bit different. First, patients were given 250 microgram bolus before ERCP, and then followed by 250 microgram per hour infusion for 11 hours after ERCP. The outcome was similar to the previous study, and around 900 patients were included in the final analysis. This is the inclusion and exclusion criteria for the trial. And this is the demographic characteristic. The mean age, BMI, history of alcohol use were similar in both groups. However, there were more male patients and smokers in the control group. No significant differences in terms of mean procedural time and time for cannulation. The result of the study showed that the incidence of PP was lower in the somatostatin group compared with the control group, as shown in the left bar chart. Overall, the study demonstrated that somatostatin with long infusion regimen significantly reduced the incidence of PEP and hyperamylasemia. The limitation of the study stemmed from the fact that the patient was not blinded and the study did not discuss other alternative regimen. However, the advantages were the large sample size and only 35% underwent pancreatic stenting. This is a double-blind single-center RCT which investigated a different regimen. The patient in the treatment group were only given somatostatin 250 microgram bolus without continual infusion after diagnostic ERCP and before therapeutic procedures. The population of the study was limited to patients who required endoscopic sphincterotomy or other therapeutic procedures. The somatostatin group was compared with the placebo group. The results showed that the incidence of PP and hyperamylasemia were also significantly lower in the somatostatin group than the placebo. However, not all trials showed positive results. This was another study, a double-blind RCT involving 510 patients randomized to the somatostatin group and the control group. The somatostatin regimen is a short-term infusion regimen with 250 microgram bolus slowly infused over 3 minutes prior to attempt at cannulation of papilla pater and immediately followed by 250 microgram per hour IV infusion for 4 hours after ERCP. The results showed that the incidence of PP was not significantly different between the somatostatin and the placebo group. Besides, subgroup analysis for patients with high risk for PP also did not show any significant difference. Limitation of this study include relatively low dose of somatostatin use and the low incidence of sphincter of OD dysfunction in patients. Because of the conflicting results, several meta-analyses have been performed. This is a meta-analysis which included 17 studies published up to 2009, investigating the efficacy of either somatostatin or octreotide in the prevention of PP. The pooled data of the overall studies, including somatostatin and octreotide, showed that the treatment group showed decreased incidence of PP compared with the comparison group. For studies only investigating somatostatin, the pooled result of 10 study also showed decreased incidence of PP with ratio of 0.52. Subgroup analysis of studies using high-dose somatostatin over 12 hours and bolus injection also showed significantly decreased incidence of PP. The subgroup analysis involving only octreotide, however, showed no significant difference between the treatment and the comparison group. One hypothesis is because octreotide administration increased the contraction of sphincter of OD instead. However, when limited to 3 studies using high dose of octreotide more than 0.5 milligram, it did show significantly decreased risk of it. Octreotide may also be effective when used in high dose. Limitation of this meta-analysis was they did not include non-English publication and instead include studies which did not describe allocation sequence and potentiometry. This is a more recent meta-analysis published in 2006 level of PP. Regarding infusion mode, it was divided into bolus dose, short-term injection, and long-term injection. The overall pooled results showed that somatostatin was associated with lower risk of developing PEP compared with placebo with a pooled odds ratio of 0.6. Subgroup analysis based on infusion mode showed that long-term infusion subgroup was also significant. Subgroup analysis of short-term infusion and bolus regimens did not show significant difference compared to the comparison group. For subgroup analysis involving only high-risk patients, administration of somatostatin also reduced the risk of PEP with odds ratio of 0.52. However, subgroup analysis involving only low-risk patients showed no significant difference on the odds of developing PEP between the two groups. Additionally, subgroup analysis limited to studies involving both high-risk patients and long-term infusion of somatostatin showed significantly lower risk of PEP. Regarding the incidence of post-ERCP hyperamylasemia, the pooled result of all studies showed no significant difference between the somatostatin and the comparison group. However, when subgroup analysis limiting to studies with only long-term infusion regimen, there was a significantly decreased odds of hyperamylasemia in the somatostatin group compared to the placebo group. The conclusion of this meta-analysis was that only somatostatin long-term infusion is effective for prevention of PP and post-ERCP hyperamylasemia, especially in high-risk patients. The recommended regimen was 250 microgram bolus 1 hour before ERCP, followed by long-term infusion with drip or pump 250 microgram per hour for at least 10 hours. The limitation was that the sample size might be considered not large enough to detect significant difference, especially for subgroup analysis. Based on the trials and meta-analysis, what did the most updated guideline says? The 2019 ESGE guideline still recommended routine rectal NSAIDs as the first-line prophylaxis strategy in all patients without contraindication. If there are contraindications such as pregnant woman more than 30 weeks gestation or first-degree relative with history of Stevens-Johnson syndrome, then the next strategy is aggressive hydration with ringer lactate unless there is a contraindication such as risk of fluid overload or presence of pancreatic stenting. Otherwise, clinician might consider sublingual anti-G. ESGE also recommended placement of pancreatic stent in high-risk patients. However, with regard to somatostatin and octreotide, ESGE made no recommendation for or against the use of those agents. They stated that most meta-analyses did show reduction in the incidence of PEP in patients given somatostatin. However, the benefit might be limited since upper value of 95% is close to 1 despite high number of patients. Having said that, ESGE stated that either long-term infusion regimen of high dose or bolus regimen may be effective in the prevention of PEP. However, regarding bolus regimen, it is felt that the number of studies are still too few to make proper recommendation. Additionally, they stated that studies using octreotide still showed conflicting data, although a high dose of more than 0.5 milligram might reduce the incidence of PEP. Finally, these are the take-home points. Based on the available current evidence, somatostatin administration may be used to decrease the incidence of PEP. The recommended regimen is still the long-term infusion regimen, such as 250 microgram bolus before ERCP, continued by 250 microgram per hour IV infusion for 11 hours after ERCP. Somatostatin may have the highest benefit in high-risk patients group. Bolus regimen may be an alternative, although further research is still needed. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Okay. Thank you, Dr. Kaka. Your presentation was very, very good and very informative. And all the participants, we have you have question you part in the screen. Okay, Dr. Kaka, thank you. And next we invite the Prof. Murdani. Prof. Murdani, you have 25 minutes, and your title is about the colorectal cancer screening, applying, and the guideline. Prof. Murdani, it's yours. Please.
Terima kasih. Thank you, Mr. Chairman, Dr. Fuad Bakri. Assalamualaikum warahmatullahi wabarakatuh. Can you hear my voice?
Yes, Prof.
I'm not
It's
sure whether
clear.
my slide has been. Can you see my slide, Dr. Furley?
Yes, Prof. Please slide.
Okay. Well, first of all, I would like to thank the organizing committee, Professor Masal Simadibrata, for inviting me to this wonderful meeting. And my text today is to talk on colorectal cancer screening, applying the guidelines. Well, this is an outline of my talk in an introduction, and these are some colorectal cancer available. And I would also to talk on colorectal cancer screening guidelines, and this a conclusion. Well, yeah, colorectal cancer is the fourth most diagnosed cancer and the third most deadly cancer worldwide, according to Globocan data. And many reports also has shown the increase of incidence and mortality of early onset colorectal cancer among young adults. Many screening strategies and guidelines have been arranged to reduce the colorectal cancer incidence and mortality. And this morning we will discuss about the colorectal cancer data and screening guidelines and how to apply them. This is a worldwide global cancer data year 2018, showing that colorectal cancer is among the highest incidence cancer worldwide. And this is a region-specific incidence, age standardized rates by sex for colorectal cancer. The highest colon cancer incidence rates are found in part of Europe, Australia, New Zealand, Northern America, and Eastern Asia, including Japan and Republic of Korea, Singapore. Uh, we can see here that Hungary and Norway among the first ranking for males and females respectively. Rates also are elevated in Uruguay among both men and women. If you look at the rectal cancer incidence rates that have a similar regional distribution, although the highest rates are seen in Korea among males and Macedonia among females. Rates of both colon and rectal cancer incidence tend to be low in most regions of Africa and Southern Asia. This is Indonesia global cancer data showing that colorectal cancer among the highest incidence cancer. And this is Indonesian global cancer data recently, year 2020. And again, it showed that if we combine colon and rectal, it is the third most common cancer in our country, according to Globocan. If you look at the trend in colorectal cancer incidence rate in adult less than 50 years in United States, the incidence rate in whites younger than 50 years have risen recently, and the incidence rate for black younger than 50 years seems to be remained generally stable. And this is a trend in colorectal cancer incidence and mortality among the last 4 decades. It raised by age, sex in United States. We can see here that CRC incidence has declined steadily over the past 2 decades in the population age 50 years and older because the combined influence of screening and changes in exposure to risk factors. But there has been a 51% increase in CRC among those younger than 50 years since 1994 because the screening not applied to those groups of age. The increased incidence rates have been particularly notable for rectal cancer, which doubled between 1991 and 2014 in individual aged 20 to 49 years old. Uh, this is a trend in colorectal cancer incidence rates by age and year of birth and by age and year of diagnosis in United States year 1975 to 2014. We can see here the recent convergence of CRC incidence rate in the group age 50 to 54 years and 55 to 59 years. In the early 1990, a CRC incidence rate in adult aged 50 to 55 years old was one half of those in the groups aged 55 to 59 years. Whereas in year 2012 and 13, there was just a 12% difference in CRC rate. The rising incidence in younger age groups coinciding with rapid decline in older age groups has led to a large shift in the age-adjusted proportion of CRC. A rapid decline in CRC incidence during the years 2000s persisted in individual age 65 years and older, among whom rates dropped by 3.3% per year. The steepest decline in this age group were for tumor in the distal colon. It looked to be 4% annually, and for localized stage disease, 5.4% annually. During the most recent data years, the annual age standardized CRC incidence rate was almost 40 per 100,000 person, and the mortality rate was 14 per 100,000 population. This is a guideline from American Cancer Society year 2018. The subject is adults more than 45 years with an average risk of colorectal cancer should undergo regular screening with a high sensitivity stool-based test or structural or visual exam. All positive results on non-colonoscopy screening test should be followed up with a timely colonoscopy. Average risk adult with a life expectancy of more than 10 years continue colorectal cancer screening through the age of 75. Clinicians decide screening for individual age 76 through 85 based on patient preference, life expectancy, health status, and prior screening history. And clinicians discourage individuals older than 85 from continuing colorectal cancer screening. These are modalities available and recommended to be used in America for high sensitivity stool-based tests. Those are fecal immunochemical test every year, high sensitivity guaiac-based fecal occult blood test every year, or multi-target stool DNA test every 3 years. But for another modalities, what we call structural or visual exams, colonoscopy should be performed every 10 years, and CT colonography or virtual colonoscopy should perform every 5 years, and flexible sigmoidoscopy every 5 years. These are some practical points how we doctors should talk to our patient concerning colorectal cancer screening, even for a fecal immunochemical test or high sensitivity guaiac-based FOBT or multi-targeted stool DNA. I think this test not available in our market until recently. Colonoscopy or CT colonography, some hospital I think can perform CT colonography in in Indonesia, and I think we familiar with flexible sigmoidoscopy. Those are some important point we need to communicate with our patient. This is a Canadian task force on preventive health care recommendation. Yeah, guaiac-based FOBT gives a significant reduction in mortality from colorectal cancer among patients aged 60 to 69 years, but no reduction among patients under 60 years. Number need to screen for colorectal cancer mortality by age group appear lower for flexible sigmoidoscopy every 10 years. These are no RCTs have reported on the mortality benefit of screening colonoscopy, computed clonography, barium enema, digital rectal examination, or fecal DNA testing. Adult more than 74 years of age who do not have illness that affect their quality of life may be less concerned with the lack of trial showing benefit or potential harm. They should discuss screening with their primary care provider to determine their most appropriate screening option based on their personal value and preferences. These are German guideline program in oncology. This guideline published in 2019. The age screening begin from age 50 for asymptomatic person. No upper age limit for screening. Colonoscopy should be standard for screening in German. A negative examination should be repeated every 10 years. What about sigmoidoscopy? Sigmoidoscopy should be offered for those who refuse colonoscopy. Annual FOBT should be performed in addition to sigmoidoscopy. This is again a German guideline program in oncology that average CRC risk who do not want a colonoscopy, FOBT should be conducted annually, and positive FOBT requires endoscopy. Capsule endoscopy, capsule colonoscopy, stool DNA, M2PK stool test, radiologic CT or MR colonography were not recommended for asymptomatic population screening in Germany. This is a Spanish Society of Medical Oncology guidelines year 2019. For individual at intermediate risk, 50 to 69 years of age, they recommended immunohistochemical fecal occult blood test, FOBT, every 2 years, and complete colonoscopy every 10 years, flexible sigmoidoscopy every 5 years. They also recommended fecal DNA analysis every 3 years and CT colonography every 5 years. but individual at intermediate risk between 50 to 69 years of age, if FOBT positive, they should complete a colonoscopy. But individual at high risk, uh, such as family or personal history of polyp or CRC or Lynch syndrome or intestinal inflammatory disease, in this case, a specific screening measures is recommended. What about Asia Pacific consensus recommendation for colorectal cancer screening? In Asia region, they developed what we call Asia Pacific CRC screening score to stratify which population should go for screening, because a big number of population and lower incidence of colorectal cancer. Using this score, we can stratify which group should go to screening. The surveillance interval depends on finding of polyps, whether hyperplastic or adenoma, and secondly, number and size of adenomas, and the presence of villous architecture and high-grade dysplasia of the adenoma, and the presence of serrated lesions or serrated polyposis syndromes, more than 20 serrated polyps of any size throughout the colon. This is a Asia Pacific recommendation on colorectal cancer screening, year 2014, screening between 50 to 75 years old, quantitative fecal immunochemical test offer the guaiac-based FOBT, and colonoscopy is considered the gold standard. And for population-based screening, FIT every 1 or 2 years for average risk, and colonoscopy every 10 years for high risk group. CT colonoscopy and capsule endoscopy are not recommended. Only for home colonoscopy is not possible. Well, this is a Chinese Society of Gastroenterology consensus year 2014. Recommendation for screening for the population age 50 to 74 years old. Preliminary screening for high-risk person is of FOBT, questionnaire, colonoscopy, and sigmoidoscopy. A 3-year screening interval, fecal DNA, and CT simulation colonoscopy are not suitable for population screening. Detection of fecal DNA and transferrin has limited importance for the diagnosis, but contributes to the screening. Two types of early CRC under endoscopy are prominent and flat. Biopsy is not recommended for the flat type. This is another guidelines, national guidelines for colorectal cancer screening in Saudi Arabia, year 2015. They strongly recommended person above the age of 45 years to go screening. No screening to be offered to person aged 70 years or older. Screening colonoscopy is recommended for no screening. Flexible sigmoidoscopy is recommended for no screening. And screening colonoscopy is recommended for colonography. Flexible sigmoidoscopy is recommended for guaiac fecal occult blood test. Screening colonoscopy is recommended over flexible sigmoidoscopy. And if you look at the guideline available for us in Indonesia, a group developed PNPK, Tata Laksana Kanker Colorectal di Indonesia, year 2018. They recommended to start the screening at age above 50 years old, doing digital rectal examination, fecal occult blood test, fecal immunochemical test every year, or endoscopy or radiology evaluation every 5 years. Um, for a moderate risk group, the screening should start at 50 years old or older. This is a group with no history of CRC or IBD, no family history of CRC, and diagnosed with adenoma or CRC above 60 years old. And for a high risk group, they define as the people which has a history of adenomatous polyp, or a person with a history of CRC curative resection, or a person with first degree family history of CRC, or history of prolonged IBD, or hereditary non-polyposis colorectal cancer, or Lynch syndrome, or familial adenomatous polyposis. The screening methods recommended is digital rectal examination for people more than 50 years old. It depends on examinator's experience. And another recommendation is guaiac-based FOBT, or fecal immunochemical test, stool assay of exfoliated DNA. If positive, those persons should refer for a colonoscopy. And the guideline also recommended endoscopy, including colonoscopy and flexible sigmoidoscopy, and also radiology, CT colonography, and double contrast barium enema. Endoscopy recommended to be performed every 5 years. This is a screening strategy for screening or surveillance for increased or high risk patient. If the patient with one or two tubular adenoma with low grade dysplasia, the surveillance should be performed every 5 to 10 years after polypectomy using colonoscopy. If the number of adenomas 3 to 10, and then the surveillance should be performed every 3 years after a polypectomy. But if the adenoma more than 10, the surveillance should be performed less than 3 years. Well, a colleague, I would like to come to a conclusion that proper colorectal cancer screening can reduce CRC incidence and mortality. However, there are national differences about when to start, stop, screening intervals, or preferred test order in general. In general, we can see in our slides before that individual age 50 to 75 should perform screening. Screening of individual less than 50 or over 25 should be individualized. Colonoscopy every 10 years, or flexible sigmoidoscopy every 5 years, and annual or biennial FOBT are the most common recommended modalities. Fecal immunochemical test is superior than guaiac-based fecal occult blood test. And colonoscopy is preferred gold standard screening, and resources availability, individual preferences should be considered in this case. And we hope that in the near future, we will have our own CRC screening guidelines developed by our society. Well, thank you, colleague. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Prof. Murdani. It's a very, very good lecture and very informative for us. And thank you very much.
Hilang
Dr.
gambarnya
Murdani.
ini kemunculannya.
The next, I invite the next speaker. I think I invite Dr. Robert Cahyadi Tejakusuma, and your title is the role endoscopy treatment in colorectal cancer. It's time yours,
Okay.
Dr. Teja.
Yeah. Can we hear the sound? Can we hear Dr. Bakri? Yeah. Thank you. Good morning, everybody. And thank you for the Mr. Chairman. Thank you for the chief of the Professor Marcel to invite me to talking about the role of endoscopy treatment in colorectal cancer, colorectal neoplasia. Ya, nggak jalan . Okay, the endoscopy that we use every day can be used for it's a cornerstone detection and prevention of CRC. The treatment, excuse me. The treatment is early stage is improve quality and life and the cure rate. And the endoscopy submucosal muscular resection, EMR, is a simple procedure and efficient to the most benign lesion. Endoscopy submucosal dissection and endoscopy full thickness, widely significant even in the colon. The endoscopy treatment is important things is the risk of lymph node metastasis. It requires limited risk of lymph metastasis associated with the tumor size, invasion depth, lymphovascular invasion, tumor bulging and degrading. And only a few techniques can be predicted before the resection. And the depth of invasion is important. It's to limit the mucosal layer. As we know that the mucosal layer is neglected and no risk of lymph node metastasis. Kikuchi has do the classification for non-polyposis lesion and divides the submucosa into 3 layers. There's the upper third, the middle third, and the lower third. And the frequency of lymph node metastasis in upper third is 2%, in middle third is 8%, and the lower third is until 25%. And tumor size and macroscopic morphology is important things to have a higher risk of submucosal invasion. The size less than 1 cm is only 1%, and 2 cm is 30%, and more than 2 cm is 30% to become a submucosal invasion. The risk factor for deep mucosal invasion were large tumor, deep depression, and invasive pit pattern. And we know this lateral spreading tumor classified into granular type and non-granular type. And other expert and Oroka has divided submucosal invasion is 40% in lateral spreading tumor in non-granulation. And we have to pay attention of vascularizing wall change, invasive pattern, and large tumor, or the independent risk of factor. Lateral spreading tumor in the granular type have a lower mucosal submucosal invasion than a non-granular type. And we see here this distribution of colonic lymphatic, and we see the mucose, and there's a muscularis mucose, and the lymphatic has been attended here in muscularis mucosa layer. And we have to pay attention of lymphatic spreading. This is a pathology, histopathology of the lymphatic spreading of the carcinoma. It's also the lymphatic spreading of adenoma. The classification is Kikuchi classification is a deep invasion into submucosa of malignant sessile polyp. And another classification is Hiroshima classification. Higrid liver is the polyposis classification for the spreading to the lymph node. Kudo pattern is also we can see the pit pattern for the possibility of the malignancy and neoplasia, and the other classification like Paris classification, Zeno, and SMSA, and Sydney classification will be talked later. We see the Kikuchi classification here is the deep invasion of submucosa of malignant sessile tumor. We see the adenocarcinoma, the third, upper third, middle third, and lower third of submucosa. And the Higgett classification is the polyposis divided into level O is carcinoma in situ in the mucosa. Level 2 invasion to the head of the polyp, and level 2 is the neck of the polyp, and the level 3 invasion to the stomach, and the level 4 invasion submucosa of bowel walls below the polyp. And here is the schema of the Kikuchi classification. Upper third, middle third, and the lower third. And this is Higgett classification of pedunculated tumor. It's a head. It's a head level 2. This is in situ. Level head is level 2, and the third is in the stalk of the polyp, and the fourth is invasion to the lower the stalk. And we know that in the conventional endoscopy in white light imaging, we can see in the macroscopically the lesions such as tumor size, lobulated excavation, stalk swelling, demarcation of area, and fullness of and fold convergency. And in magnified chromoendoscopy, we can see with the endocarmin, see the pit pattern with Kudo classification. And we see the presence of Phi pit pattern is classified into Phi1 until Phi-N. Phi1 is adenoma and severe dysplasia, and submucosal, the first carcinoma with the Phi-N is an indicator of invasion more than submucosal upper third. And we can see in the Kudo pit pattern here. And NBI, and the narrow band imaging, is optical imaging technology enhanced real-time visualization of mucosal surface structure. And it is classified by Sano classification with NBI. And there's a group of NBI international colorectal endoscopy with classification differential between the hyperplastic polyp is type 1 and adenomatous polyp in type 2. The limitation of NICE classification does not specifically incorporate this sessile serrated polyp. Sessile serrated polyp is not including in the NICE classification. And as we know, the endoscopic ultrasound can be used to staging and high diagnosis accuracy and pit pattern based on magnified endoscopy in T staging. And non-lifting sign is that lifting sign we often use in the practically for indication of polypectomy. And not lifting sign may result of peristaltic motion of fibrosis. And once the lesion is diagnosis of the superficial carcinoma, biopsy should be avoided. And the other is confocal laser endomicroscopy. Confocal laser endoscopy is a filter biopsy technique, allow real-time histological diagnosis from the endoscopy and free from conventional biopsy. It has been a sensitivity and specificity, high specificity and specificity in the diagnosis of colorectal cancer. We saw here is the Kudo classification. The type 1 is round pattern, and the type 2 is stellate pattern. The type 3 is tubular, little tubular round pattern. Type 3L is a tubular pattern. Type 4 is dendritic pattern, and type 5 is amorphous. All this type is an indication of the malignancy. As we see here, the characteristic of the normal round pattern, stellate pattern, tubular pattern, the tubular pattern, sulcus gyrus pattern, and irregular pattern. This is the Kudo classification, the feature that we see in the microvascular intensity are figure or invisible in the A type. As usual, this is inflammatory polyp. And the B type, we saw the regular surface with increased microvascular intensity here. The type C 1, 2, 3 is irregular surface of pattern, and the thickness of the distribution of vessel are homogeneous in the C1, C2. It's more irregular surface pattern and thickness distribution of vessel and heterogeneous. And as C3 is surface pattern completely unclear. It's avascular and a scattered microvascular fragment are observed here. This pattern is correlated with the management of the polyp. As we know, there's a hyperplastic polyp. If we can do nothing with in the management, and the adenoma polyp, we can do the snare polypectomy, and the high-grade adenoma, we can use the EMR, or the carcinoma, we use the and block EMR and ESD or surgery. As you see at this Hiroma classification, almost the same as Kudo as Sano classification with NBI. Type 1 is a type A. Type A is a predicted hyperplastic polyp. Type B, the tubular, is a predicted adenoma. Type B and tubular and papillary. Type C is predictive intramucosal cancer. And type C2 is predicted intramucosal cancer. And type T3 is predictive of deeply infection of submucosal cancer. This is a Kudo pattern with the dying in the polyp. And the Paris classification is divided into protruded, flat elevated, and flat lesion. That's pedunculated, protruded, and subpedunculated with a larger stalk, wider stalk, and the sessile polyp. And the flat elevation with center depression, and flat elevation with rise broad-based nodule. And the flat lesion, we see that the flat mucosa change, and the other is mucosa depression, and the other is excavation to the lower deep of submucosa. Sano classification, as we talked before, is a mesh capillary and the mesh capillary vessel, and this is a lack of uniform and high density of capillary vessel, and this one is avascular or microvascular and irregular vessel. So the SMSA is the size, morph, and here we're talking about the complication. SMSA is size, morphology, accessibility. We can do the grading here. Level divided into 4 levels, and the more higher level, the complication is more severe. We see SMSA here size. We can see the point here, the morphology. Also, we can count the point, the size, SMSA, the size of the tumor, the morphology of the tumor, if pedunculated, sessile, or flat, and the site of the tumor in the left colon or the right colon, and accessibility, and easy to access or difficult to access. And the level 1 is 4 to 5 point. Level 3, 2, 6 to 9. Level 3, 10 to 12. Level 4, 12 point. So this point is okay. The Sydney classification is talking about the injury of EMR. They divide it into type 1, type 2, type 3, type 4, type 5 after the EMR doing. We see the complication of the EMR is the submucosa and muscularis mucosa. And we can see the actual hold in the type 5 after doing the EMR. So what is the indication of endoscopy colorectal treatment? The indication for the EMR is the flat lesion 5 to 10-20 millimeter and sessile lesion. Pardon? Sessile lesion. Suspicion high-grade lesion. And the endoscopy piecemeal resection is of the larger lesion, more than 30, and large lateral spreading tumor. ESD the indication is larger indication with more than 20 in lateral spreading non-granulation, but for the granulation can be do more than 6 cm. And we see the large repression type can use the ESD and large productive type also. And ESD can be used for the mucosal tumor with submucosal fibrosis and sporadic location tumor in the condition of chronic inflammatory bowel, like ulcerative colitis. We can use the ESD. And also USD we can use for local, residual, and or recurrency early carcinoma after endoscopic resection before. The contraindication, we divide it into absolute, relative, and elective contraindication. The absolute contraindication, if they have deep invasion and ASA grade 3, the contraindication for the anesthesia and unable to bowel preparation, like an obstruction, and other contraindication for the colonoscopy. And relative contraindication with relative lesion with technical difficulty, and familial adenomyopolyposis and hereditary non-polyposis colon cancer is relative contraindication. And advanced cancer in another part of the intestinal is also the contraindication. And also another organ malignancy and short life expectancy, we have avoid the relative EMR or ESD. And tumor location not suitable for endoscopy treatment is also relative contraindication for the endoscopy EMR or ESD. And there's another elective endoscopy treatment contraindication with blood dyscrasia and acute inflammation and high fever and weakness and a poor bowel preparation is the relative elective contraindication. So the bowel preparation should be doing well, because it will detect and preconsideration in early CRC and avoid the adverse effect by the bacterial peritonitis following perforation. And we can use the polyethylene glycol in the half in the night and half in the morning before the procedure. The carbon dioxide inflammation is better than conventional air because it reduces the pain and reduce the pneumoperitoneal in case of perforation.
Robert.
Yes.
The time only.
Okay.
2 minutes left.
Okay. With the polypectomy definite treatment, cancer is not poorly. This is the definite treatment of endoscopy polypectomy. We can see here the bleeding with endoloop. Avoid the bleeding for the endoloop also. This is EMR technique. Important thing is we have to do lifting with the injection with the glycol, adrenaline, or another. And we do after lifting, we can do the pedunculate, we can do the EMR snare. Also, this is a piecemeal granulation type. This is also piecemeal EMR. This is piecemeal EMR, villous adenoma in cycle. And if there are no lifting submucosal lesion, we have to avoid to do the EMR or ESD because it's a spreading tumor invasion to the deeper. And contraindication, we can see the ulcerative lesion mark central depression, absence of lifting, type 5 pit pattern, deep infiltration. Complication is bleeding, perforation, and stenosis and post-polypectomy resection syndrome. This is end block resection. This also, we can see here we do the marking around the lesion and do elevation, and we cut off around the lesion. This is the ASD. This is the equipment of ASD, and depends on what the needle we need. And the sessile, polyp, and there's a granulation and non-granulation can be used for the ASD. This is the ASD. In this large polyp of ASD, there's a result of ASD, and all of the specimens should be taken for the examination. A disadvantage is difficult procedure, time-consuming, limited to the tertiary referral, and effective outcome is and cost-effective is still debatable. This is a complication, perforation, delayed bleeding, and post-polypectomy electrocoagulation syndrome. And histology should be made for all of the specimen on the EMR and ESD. And there is a surgical indication. If we cannot do the all of the pedunculated totally resection and poor differentiation history, histology, lymphatic venous invasion, esophageal invasion should be the operation surgery. The conclusion, and with the rapid development of endoscopy technology, endoscopy diagnosis and treatment of superficial neoplasm has been established, and still a challenge to avoid missing lesion by colonoscopy and exclude lesion with the high risk of lymph node metastasis, including lymph node involvement and poor differential before resection. Full thickness resection may apply for submucosal cancer without lymph node metastasis. In the future, the accurate endoscopic diagnosis of lymph node metastasis will be the cornerstone of lesion selection for treatment and permit real-time stratification lesion and allocate to appropriate treatment. Thus, the colorectal endoscopy therapy will help us to achieve the goal of minimally invasive treatment. Thank you for the attention.
Okay, thank you, Dr. Robert, and the speaker. And in the screen, we have 4 questions for the floor. And the first question for Dr. Kaka. What's your recommendation the pancreatic post ARCPs you have used somatostatin and the antibiotic, and when you again amnasa dan lipase. Dr. Kaka, your answer.
Thank you, Dr. Fuad. Yes, regarding the use of somatostatin for the prophylaxis for PEP, based on the evidence base, there's still some conflicting data, but from the latest meta-analysis, there is favor to the use of somatostatin. And based on the latest guidelines, there is no objection to the use of somatostatin because it shows many advantages, that is decreasing the incidence of PEP and also the incidence of the high hyperamylasemia after ERCP. The use of somatostatin itself is the bolus of 250 micrograms followed by 250 microgram per hour in 11 hours. That is the best strategies for prophylaxis PEP. this is not for the treatment, right? This is just for prophylaxis. So the strategies is bolus and then followed by uh, infusion for 11 hours. So the the infusion will be administered while we are doing the ERCP itself. But previously we do the bolus first. And then as far as for the other medication that we still the first line is the use of NSAID, rectal NSAIDs. That is the best treatment if there's no objection or no contraindication like end-stage renal disease or allergy. And we give hydration, a good hydration to prevent PEP besides somatostatin. Regarding the antibiotics, based on my presentation before, the pathophysiology of PEP also include the bacterial. Bacterial can cause PEP that enter the pancreas during the procedure. So we can also give the antibiotics for the prevention or prophylaxis for PEP. Thank you, Dr. Fuad.
Okay, thank you. Maybe the second question is for Dr. Prof. Murdani, from the RISKI, and but I recommended the screening. You tell that the screening average of 50 years, but when the historic the family historic of the colorectal cancer, maybe you can screening below the 15, maybe the younger, maybe the screening. Your comment, Dr. Prof. Dani.
Thank you, Dr. Fuad, and thank you, Dr. Rifki. I think it is an important point of screening that for a person with high risk because of history of colorectal cancer in the family, they should start screening with preferably colonoscopy, start from the age earlier, 10 years earlier, from the youngest colorectal cancer patient in the family. So it should start earlier, actually. For example, if the family suffered from cancer at 50 years old, and then the family should screen 10 years earlier, mean at 40 years old.
Okay,
Maaf,
thank you, Prof. Dani. Number 3 question is from the Lutfi. Maybe for the Dr. Robert about the Spitz-Jagger syndrome with the multiple polyp. Any procedural guideline step to prevent the cancer and malignancy? Dr. Robert,
Okay, thank you. Thank you, Dr. Lutfi. Yeah, the post-polypectomy syndrome is mean that if after we do the polypectomy, the patient will feel fever, will feel painful, and will feel abdominal pain, and sometimes as leukocytosis. That's not because of the peritonitis. This is the post-polypectomy syndrome. And for the treatment, as usual, if it's not cured by symptomatically, we can use the antibiotic for it. So this is the post-polypectomy syndrome. Yes, Yes, Nanda. Can we hear? Yes.
Yes.
And another question, maybe Dr. Fuad can repeat another question.
Okay. Tapi the last from me maybe for Dr. Kakak. When how long you can give the somatostatin? I mean many days. How long you can give? I think the somatostatin we cannot give too long.
Yeah, thank you,
Many days.
Dr. Fuad, for the question. In regards for prophylaxis, we only give just bolus continued to infusion for 12 hours. That's it. And after the procedure, if there's no, after the prophylaxis somatostatin and after ERCP, we check the amylase and lipase and other criteria for PEP, and there's no PEP, so we can stop the somatostatin. But if there's incidence of PP, we can continue the somatostatin maybe for 3 days, and we can evaluate if there's improvement, we can stop the somatostatin. Thank you, Dr. Fuad.
Okay. Maybe I mean how maximal days maybe. How long?
Yes, we know that there's some effect to the, especially to the intestine, to the constriction to the intestine. So, but if there's no proof or no sign of symptoms due to the effect of somatostatin, we can use somatostatin until the condition improve. So we have to evaluate the condition of the patients. But as far as I know that the somatostatin safe for the use for the pancreatitis. Thank you.
Okay. I think there are no questions, and I think it's time over to. Thank you for the all speaker and Dr. Teja, Prof. Mudani, and Prof. Kaka.
Welcome.
I think we have stopped our session this morning. And thank you for all the participants and for Dr. Prof. Marcel to entrusting me to be the moderator this morning. Thank you for all. I think I have to close our session, and I give bye-bye, Dr. Kaka, Dr. Mulai, Prof. Dani, Dr. Teja, and I give back
Okay.
to the microphone. Okay.
Okay, thank you very much, Dr. Fuad
Terima
Bakri
kasih.
and all speakers. Please stay still for a while. We will take a photo
Yeah.
shoot to Dr. Fuad Bakri and all speakers.
Okay.
Okay, I will count. 1, 2, 3. Okay, once more. 1, 2, 3. Okay, thank you very much to all speakers and also to Dr. Fuad Bakri.
Terima kasih, Dok.
And also thank you to Combivar as our single topic sponsor. And now please take a look at the coming video by our sponsor Combivar.
Baik, terima kasih atas kesempatan yang diberikan kepada kami pada siang hari ini. Sekilas saja, berikut adalah portofolio produk PT Combivar di bidang gastroenterologi dan hepatologi. Kami memiliki somatostatin Leomark yang mengandung 3 mg somatostatin per ampulnya yang dapat digunakan untuk kasus-kasus pendarahan atau bleeding baik pada tukak lambung, tukak duodenum maupun pada varices esofageal. Somatostatin kami ini juga sudah masuk ke dalam e-katalog sehingga dapat digunakan untuk pasien-pasien dokter yang BPJS. Untuk kasus-kasus hepatic encephalopathy, kami memiliki hepamers yang mengandung L-ornitin L-aspartat. Hepamers tersedia dalam dua bentuk sediaan, yaitu hepamers infusion yang diberikan secara parenteral dan hepamers granulat yang diberikan secara oral. Hepamers infusion mengandung 5 gram lola per ampulnya, sedangkan hepamers granulat mengandung 3 gram lola per sasetnya. Berikut adalah kriteria W7 untuk hepatic encephalopathy beserta dengan rekomendasi dosisnya. Untuk hepatic encephalopathy grade 1 dan grade 2, hepamers infusion dapat diberikan dengan cara melarutkan 4 ampul hepamers infusion ke dalam 250 ml larutan steril, kemudian didrip selama 4 jam. Untuk hepatic encephalopathy grade 3 dan grade 4, dapat diberikan hingga maksimal 8 ampul hepamers infusion yang dilarutkan ke dalam 500 ml larutan steril dan didrip selama 8 jam, sehingga tercapai dosis maksimal 40 gram lola per harinya. Sementara untuk hepamers granul, dapat diberikan 3 kali sehari, 1-2 saset. Selanjutnya, kami memiliki proteksin, yaitu suatu simbiotik yang mengandung 7 strain bakteri untuk probiotiknya, yang dilengkapi juga dengan FOS sebagai prebiotiknya. Lalu kami juga memiliki konstipen yang mengandung laktulose, yang dapat digunakan untuk kasus-kasus konstipasi maupun portal systemic encephalopathy. Selanjutnya, kami memiliki fluid enema, suatu laksatif yang diberikan melalui rektal dan bekerja secara cepat untuk kasus-kasus emergensi, dilengkapi dengan aplikator yang lembut sehingga nyaman untuk pasien. Fluid enema juga sudah masuk ke dalam e-katalog sehingga dapat digunakan untuk pasien-pasien BPJS. Selanjutnya, kami juga memiliki fosfosoda, suatu laksatif oral dengan rasa ginger lemon yang segar. Fosfosoda sudah terlisted atau sudah masuk ke dalam e-katalog sehingga dapat diresepkan untuk pasien-pasien dokter yang BPJS. Demikianlah portofolio produk PT Kombivar di bidang gastroenterologi dan hepatologi. Kami berharap produk-produk kami dapat membantu meningkatkan outcome terapi dari pasien-pasien yang sedang dokter tangani saat ini. Terima kasih atas perhatian dan kesempatan yang diberikan kepada kami.
Okay. Thank you, Kombivar, once again. Dear professors and doctor, now we almost get to the end of session. Hello?
Iya dok, silakan dok.
Okay. Dear doctors and professors, now we almost get to the end of the sessions. For the next symposium with the title, Recent Diagnosis and Treatment of GI Diseases, sponsored by Megalife, Landbeck, and ProHealth. For this symposium will be moderated by Dr. Ahmad Fauzi from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo National General Hospital, Jakarta, Indonesia. So, to Dr. Ahmad Fauzi, please, you may lead this symposium.
Thank you very much, Dr. Shirley, for this opportunity to, and of course to the organizing committee that give me opportunity to moderate this session. And I think this is the last session. Of course, thank you very much to all participants that still attached to the session. And we are now very honored to have all three speakers regarding gastroenterology medicine. And our general topic is recent diagnostic and treatment of GI disease. And of course, the first topic is with the title of New Management of Helicobacter pylori Eradication, the role of cytoprotector and probiotic. And this topic will present by Professor Abdul Aziz Rani. I think we are all well known, Professor Aziz. Professor Aziz is our father professor of gastroenterology, and Professor Aziz, a former head of Department of Internal Medicine, Faculty of Medicine, Cipto Mangunkusumo Hospital, and always active until now.
still as an advisor in our society, Indonesian Society of Gastroenterology, and also Indonesian Society for Digestive Endoscopy, and still as a counselor of Asian Pacific Society of Digestive Endoscopy. And now Prof. Aziz is head of Yayasan Gastroenterology Indonesia. And of course, we know that Professor Abdul Aziz Rani is the first who pioneered the research of Helicobacter pylori in Indonesia. So, Professor Aziz, the time is yours. Thank you very much.
Oh, yes.
Welcome, Prof.
Thank you. Can you hear me?
Yes, we
Yes,
can hear you,
very
Prof.
clear, Prof.
Okay,
Very
yes.
clear.
Okay. Balik dulu ya. Takes time. This is old man style. Don't worry.
We are happy to see you, Prof. Always get well, Prof.
Okay, thank you very much, Dr. Fauzi. So my task today is, yes, I will talk about new management on Helicobacter pylori eradication. We know already eradication of Helicobacter pylori, but I would like, can you hear me? It's okay?
Yes, very
Okay.
clear, Prof.
Okay, so I would like to talk further about PPI, we already very well known, and also additional drug or agent, cytoprotector and probiotics. So this is my talk today. So just to remind you that Helicobacter pylori is a global infection, and in Asia, initially it is estimated about the prevalence about 54.7%. The range between maybe around 50%. In Southeast Asia, a little bit low, 28.6%. But in Indonesia, sometimes there is always question mark. Is there any data from Indonesia? But for today, I will show you the data is 20% from several study, community study. So if we look at the South Asian countries, the Indonesian prevalence is 22%, almost similar with Malaysia, but lower compared to the East Asia and also South Asia like India. So this is just to show you the progress of Helicobacter pylori infection. 100% infection will cause chronic gastritis, then progress to atrophic and differentiated type gastric cancer. On the other side, chronic infection can cause ulcer, multiple lymphoma, functional dyspepsia, and other upper GI upper GI diseases, and also beyond the gastrointestinal tract may be related to idiopathic thrombocytopenic purpura and also to cancer. Just to show you the prevalence, multiple lymphoma 1%, and gastric ulcer 10%, gastric atrophy 5%, gastric cancer also 1%. We know the latest Kyoto Global Consensus report on Helicobacter pylori gastritis state that Helicobacter pylori gastritis is not a functional disease. It is an organic disease with a distinct clinical entity, and it is an infectious disease and should be treated for eradication. Therapy should be susceptibility based to prevent secondary resistance in the global in the world. So this is the basic of treatment, combination of antimicrobial, one or two, dual or triple, and the role of acid suppression with proton pump inhibitors. When we follow the consensus Maastricht 5 2017, a suitable first-line regimen considered as effective treatment if the cure rate is more than 90%. This is very important again to prevent secondary antibiotic resistance in the world. This is some factors that influencing the outcome of eradication, resistant problem, and insufficient acid inhibition. Now it's already can control by proton pump inhibitors. Virulent factors, for example, FACE genotype S2M1 or KKE in the molecular biology of this Helicobacter pylori. Environment factors should be also considered. Smoking is very important, and adherence to treatment sometimes a problem. If we look at Indonesia resistance pattern, this study by Professor Ari and Dr. showed that the metronidazole resistance is about 46.8%, levofloxacin is about 31.2%, clarithromycin is 21%, is more than the limit of 50% recommended by the Maastricht consensus. So we have to consider this resistance pattern. So if there is a sensitivity of to antibiotic, eradication rate is still, we look for triple therapy, it is about only 74, 80%. So we need another approach to reach the effective level of eradication therapy that recommended more than 90%. This is the progress or the role of antibiotic resistance concerning the eradication. If clarithromycin resistance is increasing and this rising antibiotic resistance maybe proof that we need another approach for Helicobacter pylori. In this presentation, I will show you the role of cytoprotective and also probiotics. pH control is very basic and very important for the effective eradication treatment. If we have to increase intragastric pH until 6, because at this level, microorganisms will reach the growth phase and become sensitive to antibiotic such amoxicillin. So again, the aim and target of gastric pH control is pH more than 6. It means that bacteria is more susceptible to antibiotic. If we look to this picture, we can see that the pH 6 is the optimal growth for the bacteria. Then this optimal growth become a target for acid suppression drug, proton pump inhibitors. Then it is very important for the effective antibiotic treatment. If it is less, then antibiotic treatment is not effective. If it is higher, also the growth is inhibited. It's not a good target for antibiotics. This is the mechanism of available existing proton pump inhibitor. So I think proton pump inhibitor actively form bind covalent and block the each secretion at the last level of secretion. One of the proton pump inhibitors is rabeprazole. It's already well known as a second or third generation proton pump inhibitor. I would like just to remind you, we have a sponsor that have this rabeprazole product. So the mechanism of infection suppress gastric acid secretion at secretory surface of gastric parietal cells. If we look at the onset of action, rabeprazole is faster compared to other proton pump inhibitors, only 5 minutes compared to omeprazole, lansoprazole, and pantoprazole, and which only 50% inhibit at 30 minutes. So the rational use of rabeprazole compared to other PPI, more rapid onset, then also a greater effect of intragastric pH at the first dose, So initial onset means the symptoms will be immediately managed, and it is 2 times more active than other proton pump inhibitors. So concerning the whole proton pump inhibitors, rabeprazole and esomeprazole is the fastest and most potential available proton pump inhibitor until now. Other additional effect that I think is not very common mention, maybe rabeprazole also has a protective effect on mucosal wall. So it will enhances the content of mucin and also viscosity of gastric juice. So this is an additional clinical benefit to protect our upper GI mucosa that are related to the exposed to stomach acids. That's the reason why rabeprazole must be one of the best option for the treatment of Helicobacter pylori eradication. This table just to show you, to remind you again about the first-line regimen of Helicobacter pylori eradication by ECG. You see the standard dose of proton pump inhibitors combined with clarithromycin amoxicillin, the dose already mentioned here, and also the quadruple therapy could be become the first-line regimen if there is problem of drug allergy, and also if there is a problem of high resistance for the antibiotic in the spatial region. We know there is sequential therapy. If you look at the lowest part, sequential therapy, 5-day PPI amoxicillin 2 times a day, and followed by 5 days PPI clarithromycin tinazole, totally 10 days, with the eradication rate more than 90%. This is the algorithm recommended by the Maastricht 5 2017, based on the susceptibility of clarithromycin. If it is high with low metronidazole resistance, we can combine amoxicillin, metronidazole, and PPI. Bismuth quadruple therapy is mostly effective for every resistancy level in several countries. Concomitant therapy is another combination for eradication of Helicobacter pylori for 14 days, PPI, 1 gram, clarithromycin, metronidazole. So this is a combination is already proved. It is initial empiric therapy for area with a dual resistance. So it is recommended a first-line regimen empiric treatment. If you look at this table, so the efficacy of treatment depends on the susceptible strain. If it is susceptible, the eradication rate theoretically must be higher than 90%. But if it is resistant, then the eradication rate could be very low. For this table shown by Professor Graham, it could be less than 2%. Again, if you look based on susceptible of the antibiotic, there is no drug allergy, amoxicillin is still one of the important antibiotic and can be combined with other antibiotic. This is metronidazole triple therapy, fluoroquinolone triple therapy, if it is susceptible fluoroquinolone. But if you look at that in Indonesia, the levofloxacin resistance is quite high, so it's not the best option. This is also recommended treatment regimen for Helicobacter pylori. For example, bismuth quadruple therapy consists of bismuth substrate and also bismuth substrate quadruple therapy, bismuth tablet, tetracycline, and metronidazole for our patients, sometimes this is very too strong. There are a lot of adverse effects. I think in other countries there are pre-packaged bismuth quadruple. It's not available in this country. For your consideration, this is the prevalence of Helicobacter pylori resistant rate in Indonesia. I told you, clarithromycin is 21.4%, and metronidazole almost 50%, levofloxacin 30%. So this should be considered if you want to give empiric treatment for eradication therapy. If you look at this resistance rate, maybe furazolidine, rifabutin, and quinolone citalfloxacin could be one of the options in the future because the resistance rate is very low. But for metronidazole and clarithromycin, the resistance rate is quite high. So it is not the best option for the eradication treatment. I just want to show you a study using high-dose dual therapy, which has a superior efficacy for eradication. So if you look at this treatment regimen, the high-dose dual therapy means rabeprazole 20 milligram, amoxicillin 750 milligram, given 4 times a day for 14 days. This is the high-dose dual therapy, and compared to sequential therapy and levofloxacin containing triple therapy for 7 days. If you look at the result, it was shown that result of eradication in group E1, 95.3% is quite effective. In group A2 is less, about 90%, and in group B1, 45.3%, and only 51.8% in group B2. So as a conclusion, I think high-dose dual therapy combination of amoxicillin and high-dose rabeprazole 4 times a day is superior to standard regimen as empirical first-line or rescue treatment. I would proceed further about the role of cytoprotective agent in Helicobacter pylori eradication. You know the cytoprotective agent has a role in increasing mucosecretion, production of bicarbonate, then strengthening the gastric mucosa barrier through increasing the mucosal blood flow and reduce the gastric motility. Ribavirin is one of the cytoprotective agent, and we have a study in Jakarta, the effect of anti-free radical ribavirin in patients with chronic gastritis with indicator of MDA, polyonyl aldehyde, that related to the oxidative stress. So after giving the ribavirin, after the 4 weeks, day 28, the MDA is lower than the initial level of oxidative stress. Also, it was shown that the endoscopy score is also improving. The same study in China, STAR study, I think they also gave almost similar study. The stress, oxidative stress is less after the treatment. In this study, maybe the number of patients is much higher than in the Indonesian study. The difference is statistically significant. Also, the prostaglandin after treatment is increasing. So the effect of cytoprotection also increasing. Other reports show that it is also inhibit inflammation in gastric mucosa. This is the long-term effect after 12 months. So another study showing that ribavirin improves disease meta-analysis about 600 patients. The conclusion is that supplementation of ribavirin effective in increasing the eradication rate combined with proton pump inhibitor and amoxicillin therapy. This is also another study. This is a study involving more than 1,000 patients. And this meta-analysis showed that ribavirin significantly increase the eradication rate with the odds ratio 1.753. So it is quite effective. This is a forest plot showing the odds ratio about 1.753 in this meta-analysis. So it is quite strong evidence to add ribamapide for eradication. Another alternative is additional of of probiotic. We know that probiotics can reduce the side effect initially, then also it was shown that can improve the eradication rate and alleviate the side effect. So we know that most probiotic colonize the human gut, but some probiotic can colonize the human stomach directly or indirectly, antagonizing the Helicobacter pylori. In this picture, we can see some mechanism of probiotic against Helicobacter pylori, secretion of antibacterial substances, inhibit adhesion, and improving or enhance mucous barrier and modulation of immune response. So it is again a very convincing theoretical base for application of probiotic for eradication Helicobacter pylori treatment. This is the mechanism of colonization at the gastric cavity and also in the gastric mucosa. One of important thing is the biofilm that protect the Helicobacter pylori, and as well also this biofilm formation protect the Helicobacter pylori and produce the antioxidant enzyme. So biofilm it is very important, and probiotic in this eradication treatment can destroy the biofilm to enable the administration of reduced antibiotic dose. So in conclusion, probiotic have a killing effect on Helicobacter biofilm and may improve the effect of antibiotic and also reduce the adverse effect of antibiotic. Probiotic also secrete lactic acid. Lactic acid inhibit growth, drug-sensitive and resistant Helicobacter pylori, and also produce bactericin and also reuteri in some other probiotics. The other probiotics is yeast, Saccharomyces boulardii. This yeast can repair and enhance gastric mucosal barrier and help the host to prevent Helicobacter pylori colonization. So this is mechanism of action of Saccharomyces boulardii against Helicobacter pylori. The size is about 10 micrometers, 10 times larger than the common bacterial strain of pericarditis. So it is effective to of Helicobacter pylori. Also secrete antibacterial substances and also regulate immune responses. This is some study showing that probiotic can improve the efficacy of antibiotic. If we look at this table, with Saccharomyces boulardii for 4 weeks can improve the eradication and also reduce the side effect studied by Dr. Song. This is also another study. This is a single strain probiotic, in this case Saccharomyces boulardii, a prospective randomized control trial. Eradication rate is higher compared to no probiotics, and also a study by Dr. Zhu. This is a randomized clinical trial. So recommendation for Saccharomyces boulardii in adult, if we look for Helicobacter pylori symptoms, the dose is 1,000 milligrams per day, the duration 2 weeks, combined with standard triple therapy, and the strength of evidence, scientific evidence, is quite strong. To summarize, we know that Helicobacter pylori consistently cause inflammation, chronic inflammation, and cause some serious gastroduodenal diseases, peptic ulcer, lymphoma, and gastric cancer. It is globally high prevalent, but now decreasing. And the problem in the management is high antimicrobial resistance in the whole world. So it means that we need to approach this problem with additional treatment. In this case, maybe there is some role of cytoprotective drugs, right, like rimamabide and probiotic, like Saccharomyces boulardii, to improve eradication rate of Helicobacter pylori eradication and reduce the adverse effect. In the future, I think what is very important, the treatment regimen should be susceptible based because of risk of primary resistance globally. So I hope we can treat the Helicobacter pylori effectively and also safely. Thank you very much for your kind attention. Thank you very much.
Thank you very much, Prof, for this very good lecture presentation. And of course, with the beautiful catch eye slide and comprehensive explain about H. pylori management and of course the importance of a cytoprotector and probiotic. Thank you very much, Prof. And now we will move to the second topic with speaker Dr. Andri. Welcome to Dr. Andri with the topic title is Recognizing Generalized Anxiety Disorder and Irritable Bowel Syndrome and Functional Dyspepsia. Dr. Andri is a psychiatrist. Dr. Andri is head of psychiatric and neurology division of the hospital. Of course, Dr. Andri postgraduate from Department of Psychiatry, Faculty of Medicine, University of Indonesia, and former research head of research in Krida Wacana University, Christian University, and in Atmajaya University also. And Dr. Andri is a peer reviewer of several journals and now still active in Majalah Kedokteran Indonesia, Medical Journal of Indonesian Society. And of course, Dr. Andri is an expert in psychosomatic medicine and very active and published about this regarding expert. So thank you and welcome, Dr. Andri. The time is yours.
Thank you, Dr. Atmal Fauzi. I will sorry. Thank you, Dr. Atmal Fauzi and all the colleagues and professor. I'm very honored to be part of this Jakarta International GI Endoscopic Symposium. And today I will take this opportunity to present about the recognizing generalized anxiety disorder in irritable bowel syndrome and functional dyspepsia. We know that the pandemic is an emerging and also kind of like an more effects in our daily lives. And also the problems in our medical practice now, it's kind of like related to the increasing numbers of anxiety problems in our daily practice. I am as a psychiatrist and my daily practice in a general hospital, see a patient with a hot issue like this, and it is related also to the medical problems related to the gastrointestinal problems and also other problems like cardiovascular problems and diabetes mellitus. But the problem is now is when we call the pandemic and related of the psychiatric problems, we know from the studies recently in the CDC in the United States that there's an increasing amount of anxiety compared to the pre-COVID situations. And it will be more difficult to understand that sometimes we know that this is also related to Indonesians' problems. I have a report from the Indonesian Psychiatric Associations that conduct the survey during the 5 months COVID-19 in Indonesia, and it shows that more than 64% of the respondents has psychological problems. More than that, 71 is female and 20% of males. But the problem is during the pandemic is the increasing amount of anxiety, depression, and traumatic events. It's not only about the psychiatric problems, but it also has some connection with the problems in physical medicines or physical problems itself. So I think we have to consider again, and we have to remind us again, the differences between what is the normal anxiety and the generalized anxiety disorder as a disease entity. We know that when we see a patient with generalized anxiety disorder, the anxiety become constant, and it has also some of the symptoms like irritability, insomnia, and difficulty in concentration. But also they have also the some physical symptoms like restlessness, muscle aches, pain, and also the fatigue. And if we see the DSM-5 as a criteria diagnostic for the all the anxiety, it will be mentioned that if the patient have the excessive anxiety and worry more than 6 months, and it's also difficult to control and has some effects in their daily life and cannot be function well as it before, and sometimes it's more likely to have symptoms more than a psychological symptoms, because some of the maybe some of the colleagues said, oh, this is only about the symptoms of psychological, but in our daily practice we often see that the patients also has some problems, not only in the problem related to the psychological but also for the physical problem itself. In this Hamilton anxiety rates rating scale, it's a battery, it's a screening tools for the patients that can we define this is a severe, moderate, or uh, mild anxiety problem. There is a kind of like a symptoms related not only to psychological, but also related to the physical problems like cardiovascular symptoms or gastrointestinal symptoms, and also the respiratory symptoms like we see in this presentation. In our daily practice, as I mentioned in the Indonesian Psychiatric Associations, we know that the General Anxiety Depression Scale G87 is a very compact and also useful tools for us, not as only as a psychiatrist, but also to the general practitioner to divine or to differentiate between the two of the anxiety as a disorder or as a normal anxiety itself. So it seems to be not really difficult to define the general anxiety disorder, and maybe in our daily practice we can give this questionnaire, this battery of screening tools to the patients while they are waiting in the waiting room before we examine the patient. So Today, I'm very honored to join the meeting related to the gastrointestinal problems, and I hope this interaction between gut health and psychiatric health that we mentioned before in our uh, previous slide, that there are some of the symptoms that not only related to psychological problems, but also related to the physical problems and also the cognitive problem. So in the past, maybe we just consider the depression as a symptoms of psychological mood, but today, we have also considered that this is a kind like a physical mood, and it's also kind like a hand in hand, especially in the patients of the younger or the younger generation, the millennial age. They have also some of the clinical problem related to the cognitive. But today we are going to stress in the stomach problems itself. So a patient who come to the clinic, I see every day, there's a lot of patients with also has a symptoms in their stomach or their this gut. And if we see the situation and also the studies before, we know that 90% of the patients with irritable bowel syndrome have at least one comorbid psychiatric illness. And like Professor Aziz Rani said about the probiotics, we know that recently there's an increasing amount and upraising an awareness about the microbiota, like the Hippocrates said in the early age of this century, that related to the what we eat is what we are going to have in our daily healthy life. But in the absence of also the microbiota and germ-free in the study with the mice and mouse and the research, it also has some effects in the anxiety problem. I know back in 2017 in the World Congress of Psychiatry in Berlin, there is a kind of a researchers that connected that the problems of the gut microbiota with the anxiety and depression problems. And it also has some effect also in preventing the patients with anxiety related to the gut health problem also. So in our daily practice, we know that the patients with a kind of major depressive disorder has two kinds of uh, symptoms related to the appetite. One is the classic one is what we call the depression with decreased appetite. We know that this kind of patients with the predominantly melancholic depression or classic depression, mood symptoms that has a low mood, and also regarding to the problems as sadness, what we call it. But today, especially in the young age, in the millennial, they have also related to the increased appetite of eating when they have a depression. So what we call in our daily practice life as a psychological eating, they are have a kind of symptoms, mood disorder, but also they have a increasing appetite related to this. And the problems of the gut health and psychiatric health, I think we know that in our clinical practice, the symptoms also related to the stress. But our recent studies and our background about relating the serotonin and the dopamine as the neurotransmitter that related to the mood symptoms all produced and synthesized in the gut. So I think within the acronym, what we call it, the DA or the dopamine and 5-HT, the serotonin symptoms of the problem related to the gut. And also, if there's something with the gut, there will be something with the brain, also all the psychological problem. So in these situations, I think the gut health and psychiatric health will go hand in hand, and the collaboration between psychiatrists and also others, general practitioners, and also the internal medicines, especially the gastroenterologists, will be one of the best collaborations facing these particular patients in our clinical practice. So what is the problem with the stress and related to the gut problems? When we see these models, I think that we have to understand again that the visceral hypersensitivity and the neurochemistry of the brain related to the also related to the gut system, like the serotonin and dopamine, is come from the early stress in the childhood. And the model of the rat model and will be really related to the anxiety, the increase is colonic transit, the intestinal permeability. So when the patient asks me about how can you manage the problem of my anxiety and also the gut system, is there any connection? I think there is a connection. Of course, there is a connection, but the problem is sometimes they don't really understand how is the connection is. So this is what we call it the early when we ask about the patient's symptoms of anxiety or disorder of mood symptoms. There is a complex situations related to this, the basic mechanism of the patients and also have some effects in the in the prognosis and also the pathophysiology of this the disorder, because many patients has also many backgrounds, and there is a kind of like a early traumatic related to genetic variations and also the environment, so it can be related to the epigenetic itself. So if we see that this kind of stress, this is the classic model of stress which related to the HPA axis, the cortisol. We know that if we are stressed enough and then the cortisol level will be uprising. But in the meantime, the problem is we need also the cortisol. If we don't have a cortisol in our body, there will be a trouble also. But how to get more what we call it balancing related to the problem of anxiety and also the immune systems that also has some problems in our pandemic today. So if we call it in our daily practice, we kind like mention the but brain gut axis or the gut brain interaction, and it is often characterized by the visceral hypersensitivity and GI motility dysfunction. These two kinds of uh, problems also we are facing in our daily practice when we see a patient with ulcer-like syndrome or maybe like a dysmotility-like syndrome. They have complaining about bloating or pain relief, and about 1/3 of the general population has some referral centers to the psychiatric comorbidity. So I think when we see a patient with problem of the anxiety and also the dysmotility like problems related to the gut symptom, maybe we have to consider to ask them, is there any particular problems or is there any trigger related to the brain, to the gut problems or the gut symptom? Maybe there is a correlation of the depression, or maybe there is a comorbid between them. So considering the link between brain and gut, to what extent irritable bowel syndrome is one of the symptoms that has been very connected to the irritable brain. So we know that sometimes when people say that I am very confused, I am very stressed, and I have a stomach ache, and it's also related to psychological stress, and maybe it's the primary event. And without any hesitate, we can say that because sometimes there is no relation of the other foods or maybe to the kind of like a daily activities of the patient, but only stress that can trigger the stomach ache symptoms, and it's very common in our daily practice as general practitioners or in internal medicine specialists. So These are the case study about what we see, and maybe it's only about the vignettes studies about what we see in our daily practice life. The patients, male, 29 years old, complain about the bloating and also felt that eating become more uncomfortable for them. And also after a month of symptomatic treatment, there was no significant change. The patients has performed a gastroscopic and the result was relatively normal. And the treatments, the symptomatic treatment continued. And the problem is the symptom of anxiety began in the second month of the patient treatment. The patient also felt the symptoms of bloating to this day. All the examinations, supporting examinations like endoscopy, ECG, treadmill ECG, echocardiography has been conducted to the patients, and all findings were relatively normal. And they have been examined also and given symptomatic medication by gastroenterologists, neurologists, cardiologists, and internists, because we know that these patients sometimes have, as a custom, has a like a shopping doctor or doctor shopping. Working diagnosis at this moment is a somatic symptom disorder. I have a differential diagnosis to the generalized anxiety disorder, but because of the patients has been only 2 months period of time having anxiety, we have to dig deep inside the patient, or whether there is a kind of a history of anxiety disorder before. But the treatment goals is for the patients has a worry about stomach ache symptom, excessive anxiety with anxiety problems like palpitation and shortness of breath, and negative thoughts about how become worse and become severe, and also has a complaining and difficulty in sleeping. I think the relieving the symptoms of anxiety and somatic symptoms will be the best idea for now. So, is there a role of psychopharmacotherapy in functional dyspepsia? From many RCT studies and also many studies before, there is a kind of awareness that the amitriptyline and also all the serotonins medication has some effects in the treatments of the functional gastrointestinal problems. It is because the relationship between there is a positive effects of using serotonin medication to reduce the symptoms of dyspepsia, reducing the hypersensitivity and also reducing the problem related to the bloating or even sometimes the ulcer-like syndrome. So I think this is one of the ideas that maybe we can put in our mind, in our daily practice, that the small dose of antidepressant, especially the citalopram and the fluoxetine, all are the SSRIs medication, is an effective and well-tolerated treatment option to improve symptoms in refractory functional disorder with the minimal side effects and also satisfaction with the patient's daily activity. Some of the patients has still more likely to use the PPI and the prokinetic as a symptom-based medication. And it's very common, and it's supporting medication, and it's fine. But the symptoms improvement in many of the patients related to the use of medications like SSRI, as escitalopram or fluoxetine, it's a certain kind of has been very good. And I think the symptoms remissions is more than 50% of the average time with the obtain of remissions about was 3 or 4 months. So we are likely to have a patient like this in our daily practice. They complaining about the symptoms of gastrointestinal and also the anxiety problems. And I think using this kind of particular medications is quite beneficial for the patient. And we have to see the patient also has a comorbid of anxiety itself. So this one of the benefits of the antidepressants in functional dyspepsia, we know in our daily practice, we often see that the amitriptyline and escitalopram as the as the main use of the medication in our functional dyspepsia. So we have to differentiate between them. What is the benefit in our symptoms related to the patient comparing to amitriptyline and escitalopram? For the symptoms of delayed gastric emptying, the adequate relief is mentioned that amitriptyline has the adequate relief compared to escitalopram. But if we compare the delayed gastric emptying and dysmotility-like symptoms, it was said that escitalopram and amitriptyline both are improve overall quality of life and the symptom. I know most of the seniors, sometimes they also have prefer to use amitriptyline to the patient with ulcer-like syndrome. And it is best known for that, and it's okay still now. But I think we have to consider that the side effects of the amitriptyline in the patients with the cardiovascular problems, we have to be very careful, and also to the patients, male patients above 50 years old patients. And using the amitriptyline, it is not recommended because it can be trigger the QT prolongations in the heart of the patient. So the role antidepressant as a summary that the TCAs were found to work better in patients without depression and anxiety, while SSRIs were better for patients with anxiety or depression. So as I mentioned before, if we have a patient that has comorbid anxiety and depression, and it's sometimes difficult to patients to accept that their symptoms of gut problems is related to both the anxiety or depression symptoms of psychological problem, I think it's a wise way also to put on the medications related to the symptoms of anxiety like SSRI for the patients in this particular condition. So these are the guidelines in our daily practice for the patients, and how can we use some medication related to the SSRIs as antidepressants or TCAs as older antidepressant to the patient. So when anxiety and depressions and phobic features are prominent with functional gastrointestinal disorder, maybe we can use the SSRIs, but when there is a predominant pain, maybe we can add some TCAs or amitriptyline as a low dose of amitriptyline. But we have to consider that the patient has also free from the problem of cardiovascular problems. So as a take-home message, I think the functional disorder symptoms over interfere with the school, work, and very much demanding problems in our clinical practice. The FD symptoms management remains challenging. Treatment may include dietary modification, of course, anti-emetics, antispasmodic, prokinetics, and analgesics sometimes. But when we see a patient with psychological symptoms or the comorbid of anxiety or depression, maybe we can add some antidepressants like TCAs or the newest drugs like SSRIs as the safest one to be shown as some effects from the perspective of the patients and also from the clinical point of view. Both are the recommendations for the patients with anxiety and the problem with depression, but studies found that SSRI like escitalopram will be beneficial compared to TCAs in the patients with anxiety and depression problems. I think that's the presentation for today. I'm very thankful for the opportunity to share this information with you, all the colleagues and professor, and I hope we can discuss these presentations after this session. Thank you very much, Dr. Fauzi.
Thank you very much, Dr. Andri, for your very good and comprehensive lectures about NCT in related to the GI disorder. I think this is an interesting topic, and I hope my stomach ache right now is not due to the anxiety becoming a moderator, but maybe because of not get lunch yet. I think some question will coming to the interesting topic. We will wait. And now we move to the last speaker. The last speaker, I think we are well known. Who will be presented by Professor Murdari Abdullah with the topic the role of hyaluronic acid tropical topical in colitis. We are all know that Professor Murdani is a very active and Indonesia, and Professor Murdani head of division of gastroenterology and former secretary general of Indonesian Society of Gastrointestinal Endoscopy, and now is vice president of Indonesian Society of Gastrointestinal Endoscopy, and of course very active in abroad uh, abroad also. So please, Professor Murdani, the time is yours.
Well, thank you, Mr. Chairman, Dr. Ahmad Fauzi, for your kind introduction. Well, a very good afternoon, professors, seniors, and colleagues. Well, I would like to thank also the organized committee, Professor Marcelo Simadibrata, for the invitation. And my topic today is the role of topical hyaluronic acid in colitis. Can you see my slide? Well, I would like to start with the fact that pathogenesis of inflammatory bowel disease is associated with disrupted intestinal barrier function, imbalance of gut microbiome, and subsequent dysregulated mucosal immune responses to gut commensal bacteria. Traditional medical interventions for IBDs have mainly focused on managing the symptoms of IBDs by suppressing immune responses. However, they generally do not address the underlying causes of IBDs, including damage to the mucous layer in the gastrointestinal tract, subsequent loss of intestinal barriers function, and dysbiosis of gut commensal microorganism. Moreover, despite advances in localized drug delivery, conventional immunosuppressive drugs based on small molecules or biologic can cause off-target systemic side effect, and their long-term use may lead to serious complications such as opportunistic infection, malignancies, autoimmunity, and liver toxicity. Toward the goal of addressing this unmet medical need, researchers have developed a nanotherapeutic platform that can target inflamed clonic epitheliums, modulate the gut microbiome, and promote anti-inflammatory immune response in local tissues with improved efficacy compared with traditional IBD therapeutics in murine models of acute colitis. if you look at the incidence of IBD, it showed that the incidence quite varies among the Asia countries. It's range from 0.54 to 3.44 per 100,000 population. And from Asia Pacific data, it showed that ulcerative colitis more prevalence compared to Crohn's disease. In Indonesia, the data we have last year from several centers in Indonesia showed a similar problem that ulcerative colitis seem to be more compared to Crohn's disease. Well, this is two kinds of very prevalence type of IBD, what we call Crohn's disease and ulcerative colitis, with some difference in pathogenesis and also in the endoscopic appearance. This is a colonoscopy figures of both ulcerative colitis and Crohn's disease. Well, this is what we found that several small and early studies analyzed various other therapeutic approach, some with promising but not convincing results to recommend their use in clinical practice. Liquid enemas with cyclosporin initially look promising in open label studies, but were not shown to be active in placebo-controlled randomized trial. Butyrate enemas were likewise promising in open label studies, but not in placebo-controlled randomized trial. Also, nicotine enemas containing 6 milligrams of nicotine have been studied in a large randomized double-blind study, including more than 100 patients with active ulcerative colitis. And the topical nicotine was not found to be efficacious for active ulcerative colitis. Further therapeutic strategies include the use of lidocaine, icabet, and epidermal growth factors, ribamipide, and thromboxane enemas now in some trial. Well, next, I would like to try to review some anti-inflammatory mechanism of hyaluronic acid. Well, hyaluronic acid is a non-sulfated unbranched polysaccharide. Hyaluronan is synthesized by hyaluronic acid synthase enzymes as a single long-chain polymer reaching size up to 10 millidalton and has a broad range of biological activities in mammalian tissues. It is a ubiquitous component of the extracellular matrix with a key role in tissues hemostasis and is required for development, reproductive biology, and immune function, exerting both structural and signaling activities. The control of hyaluronic acid synthesis is therefore critical in extracellular matrix and cell biology. Under normal physiological conditions, high molecular weight hyaluronan suppresses the immune responses, acting as anti-inflammatory molecules, act as an anti-angiogenic factor, and exert numerous receptor-mediated effects on cell adhesion, migration, mitosis, and inflammation. The hyaluronic acid receptor CD44, which is expressed by a wide range of cell types, mediates many, but not all, of hyaluronic acid's biological activities. Hyaluronic acid also has an important role in regulating the hydration of tissues, in part through its organization and retention of chondroitin sulfate proteoglycan. Moreover, it is a component of the glycocalyx on epithelial cell surfaces that provide a protective barrier for tissues. However, upon tissue injury, high molecular weight hyaluronic acid is broken down by a family of enzymes called hyaluronidases, releasing low molecular weight hyaluronic acid fragments. These species have been reported as having a wide range of effects, including promoting tissue repair, stimulating the immune response, influencing tissue fibrosis, and acting as pro-angiogenic factors. The molecular mechanism by which hyaluronic acid exert its physiological and pathological functions are still incompletely understood, but its interaction with specific hyaluronic acid binding protein are likely to be central to its diverse functions. Moreover, hyaluronic acid has been found to have potential for tissue remodeling and acceleration of wound repair and tissue restoration. Recently, we have shown that the local application of a new formulation of a sodium hyaluronic gel improve endoscopic and clinical outcomes in subjects with active distal ulcerative colitis. This is immunofluorescence staining of hyaluronic acid, small molecules, treated mouse intestinal organoids that showed internalized of hyaluronic acid, shown in green color, and increased zonula occludens, a cytoplasmic scaffolding expression at the figure, the first figure at left side. If you compare to the right side, it's bigger molecules of hyaluronic acid treated mouse intestinal organoids, which show no uptake of hyaluronic acid, shown in green color. This immunochemical, immunohistochemical staining for hyaluronic acid was performed using biotinylated hyaluronic acid binding protein. This in vitro study showed large hyaluronic acid is able to reach the surface of the cells in vitro, but it is not internalized by cells, unlike a small size of hyaluronic acid, 35 kilodalton. This data indicate that the internalization of hyaluronic acid is size dependent and may not occur with large size of hyaluronic acid. Well, in this slide, we can see that hyaluronic acid is a natural product and is present in human milk at the highest level immediately postpartum, which support the notion of its participation in process of maturing the neonatal digestive system. A number of preclinical studies highlight functions of exogenous hyaluronic acid promoting intestinal epithelial defense mechanisms and inhibiting bacterial infections in the intestine. Effect of exogenous hyaluronic acid treatment on the intestinal have been investigated in multiple studies looking at oral and intraperitoneal delivery in vivo. In the case of orally delivered hyaluronic acid, small molecule appears to be the most potent size of hyaluronic acid for protection of intestinal epithelium. Throughout the numerous clinical trials of hyaluronic acid, intra-articular injection, and oral delivery for osteoarthritis patients, as well as clinical usage of hyaluronic acid in ophthalmology, the safety of using hyaluronic acid as a therapeutic modality appears to be the most promising one. Well, next, I would like to show some study available in literature on the role of topical hyaluronic acid in colitis. This study, an experimental on mice, moderate colitis induced by DSA 3% for 5 days, and hyaluronic acid 1 milligram 1 mg per ml or saline every other day via enema started on day 6. And it seemed that hyaluronic acids accelerates the recovery phase after colitis insult. It showed better weight recovery with hyaluronic acid, 100% compared to 90% in control group. And it also showed a rapid weight gain correlated with reduced bleeding score and significant statistically. This is mucosal appearance from both group. We can see here in saline group, marked granularity of the mucosal surface and marked thickening of the colon wall and mucosal erosion. While in hyaluronic acid group, mild endoscopic colitis grading and moderate thickening of the colon wall and moderate changes of the vascular pattern and mild mucosal bleeding. Well, this is another study, an experimental on rats. Hyaluronic acid as adjunctive therapy with topical 5-ASA. And in this case, colitis induced with TNBS. We can see here that the group with hyaluronic acid and 5-ASA synergically reduce myeloperoxidase compared with other treatment. We can see in this slide that TNF-alpha gene expression more significantly decreased after combined treatment with hyaluronic acid and 5-ASA compared to the group with 5-ASA alone. And the level of interleukin-1 beta and interleukin-6 did not differ significantly. This is another result that macroscopic appearance among the group of hyaluronic acid and 5-ASA synergistic protective effect compared with other treatment. These are another study from the group of Italia. This study to show the safety and efficacy of sodium hyaluronate enema in distal active ulcerative colitis in a prospective uncontrolled open-label pilot trial. This is a small study, actually, and the primary endpoint from the study were the safety and clinical response rate at day 28. Yeah, so only 4 weeks. And the secondary endpoint included clinical remission, endoscopic remission, and tolerability of hyaluronic acid. In conclusion, the researcher conclude that the hyaluronic acid seems to be safe and effective for the induction of clinical and endoscopic remission. placebo-controlled studies are warranted. Well, this is another result of the study. To show a clinical and endoscopic response seem to be better among the hyaluronic acid group, and also some other result, clinical endoscopic remission rates with hyaluronic acid at week 4. The rate of mucosal healing indicates a subject with endoscopic subscore 0. Well, concerning the reports of adverse event, we can see here that all adverse events are categorized as mild, except one case of worsening of symptoms, and 27% complained difficulties with rectal self-administration, consistent with the literature on enema tolerability. This is a possible side effect of topical therapy: leakage, bloating, urgency, and these are some serious complications such as rectal perforation, but very rare. Also, some systemic side effect, also rare. The challenges are almost 33 of subjects in literature report difficulties in self-administering enema. And another challenges are proctitis or proctosigmoiditis can reduce rectum tolerability to topical treatment. These are another study also from Italy. The objective of this study is systematically review the published literature regarding the therapeutic activities of hyaluronic acid in topical formulations, highlighting the safety and the tolerability of this molecule with attention for hyaluronic acid-based treatments of anorectal tissue exposed to radiotherapy. And they conclude that hyaluronic acid confirmed its totally safety profile and resulted effective in the inflammation decrease, improving the tissue health and the symptoms related. Well, in summary, I should say that hyaluronic acid should be investigated further as an effective and well-tolerated adjunctive therapy in treating colitis. Blinded controlled trial on humans with larger sample size is still needed. Reported side effects are mostly mild, and challenges include difficulties in rectal self-administration and reduced tolerability in proctitis patient. Well, thank you, colleague, for your kind attention. Thank you.
Thank you very much, Prof. Murdani, for this very comprehensive, well-informed about this agent of hyaluronic acid as an alternative maybe in treatment of GI disease, especially colitis. And we have time limit 5 minutes. Maybe can discuss several questions, just several questions. Maybe to the question comes from to Professor Aziz from Dr. Andi Zainal. Prof. Aziz, how about the amoxicillin resistance for H. pylori in Indonesia? How is the situation of amoxicillin resistance, and what kind of probiotic recommended for eradication of H. pylori? Thank you, Prof.
Thank you for the question, Dr. Andi, my old friend. I think amoxicillin is a less resistant antibiotic in the regimen treatment for Helicobacter pylori eradication. I think the rate of resistance may be around 5% or less. I think there is a report about 9% resistance rate for amoxicillin. But if compare the resistant rate, the level of resistance rate for clarithromycin recommended by the many algorithm, I think it's still very useful and effective to combine amoxicillin as one of the antibiotic. If you look at the dual therapy, the other way to overcome the resistance is to give it in more frequent administration per day. For example, 4 times a day, 750 milligram, so 3 grams. So this is, I think, just based on the several clinical study. But basically, the amoxicillin resistance is still quite low. So it is still very useful for the treatment of Helicobacter pylori eradication. I hope I can answer.
And what about the, yes, Prof, it's clear. And what about the probiotic, Prof? It can
Oh,
also concomitant eradicate H.
yeah,
pylori.
yeah. I think treatment with probiotic has a broad base, theoretical base. So it can be many GI disorders. For Helicobacter pylori, we just look at the uh, clinical trial. For example, in this presentation, we check that Saccharomyces boulardii is one of the probiotic. It is a yeast that given 1,000 milligram per day for 4 weeks give a good result to increase the efficacy of treatment and also to reduce the adverse effect. So I don't have a specific recommendation for probiotic, but because probiotic treatment is based on the broad-based theoretical base, I think you can check the study and the study better if you can find the randomized control trial. The available probiotic in Indonesia, I think you can also use a single probiotic or combined with prebiotic.
And is there a potential long-term side effect of this probiotic, Prof? The question also from Dr. Andi Zaina.
Yeah, I think the most important profile of probiotic, it is quite safe, except for patients with immunocompromised. So the adverse effect also mostly mild, and the adverse effect usually to gastrointestinal tract, maybe mild bloating, or some patient also get some mild diarrhea. So it is not very clinically significant. So what I recommend is just try to continue the probiotic, or you can switch to another probiotic if the adverse effect is maybe a little bit disturbing the patient. So it is quite safe actually. Yes, in the short term and also in the long term. The adverse effect
Thank you very
usually.
much, Prof.
Okay.
Yes, thank you very much, Prof. And there are questions also to Dr. Andri. Use psychotherapy in combination with medication for the management of uh, functional dyspepsia. I think
Certainly, sir.
can the drug, antidepressant drug, can actual symptom of dyspepsia?
Certainly, because we know that the combinations of psychotherapy and pharmacotherapy is the best way to treat the patient with anxiety and depression. But sometimes because of the limitations of time that we face today during pandemic, I myself only see a patient about 20 minutes per patient, and it's very hard to use psychotherapy for only have a 20 minutes period of time when we see in the patient in clinical practice. But I also recommended patients to see a psychotherapist or psychologist if they have some issues that related to the personality problems of the anxiety itself. But I think the best way to
know that the psychosomatic problems, especially related to the symptoms of gut problems or gastrointestinal problems, I think the first time we have to do the somatics problems, we have to deal with the somatics problem itself and reducing the symptoms that will be very beneficial to the patients. And also we have to consider that some of the personality background will be the, the background or the underlying cause of the disorder itself. So I think will be good idea also to has psychotherapy and also the pharmacotherapy, but because of the limitations of time and the situation during pandemic this time now, it's a very obstacle to us also as a psychiatrist. Thank you very much, Dr. Fauzi.
Thank you very much, Dr. Andri. And there is question to Professor Murdani. Is there oral preparation of the hyaluronic acid and how to deliver this this agent for colitis? And thank you very much for Prof. Murdani.
Yeah, thank you, Dr. Fauzi. It's a very important point of hyaluronic acid because there are very few data on the oral use of hyaluronic acid as regard the pharmacodynamic and pharmacokinetic of the substances. So the only data we have mostly local topical use of this new promising agent. These are I'm not sure whether there is any good clinical trial to show the efficacy of hyaluronic acid by oral use. Thank you.
Thank you, Prof. Well, I'm sorry because of the time's limit, and of course, some questions were wondering about this topic. I think all the doctors can contact personally to all the speakers, of course. And thank you very much for the all speaker for have time to speak in this session. And thank you very much to the participant. And I will send back this time to Dr. Philly as master ceremony. Thank you very much.
Okay, thank you very much to Dr. Ahmad Fauzi and also to all speakers. Now we will take a photo shoot. So please stand by. I will count 1, 2, 3. Okay, very good. Once more. 1, 2, 3. Okay, thank you very much to all speakers and Dr. Ahmad Fauzi to very insightful symposium. And also thank you to Megalife, Landbeck, and ProHealth as our sponsors. And now please take a look at the coming video by our sponsors, Megalife, Landbeck, and ProHealth.
As healthcare professionals, we understand the need for your continuing medical education each year. Furthermore, the pandemic and travel restrictions have made it difficult to attend congresses, both locally and globally. Brainmaster is a platform for healthcare professionals who need access to fast, effective, and convenient information regarding psychiatry and neurology through a series of webinar events suited to your needs. Simply browse and select your country on Brainmaster to pre-register for upcoming webinars, or even choose from recorded webinars to watch on your own time. And some of these webinars are also CME accredited. Now, you don't have to worry about physically attending meetings and Congress to get the valuable medical information and education you need. To access, log on to sea.progress.im and click on the Brainmaster banner, or visit cmesea.com to select the webinars available for you. Brainmaster, your one-stop center for webinars around the world.
Okay, dear professors, doctors, and colleagues, now we almost got to the end of our sessions. And for now, we would like to invite our Honorable Chairman of Virtual GIGAS 2021, Professor Marcellus Simadibrata, to present his closing remarks. So to Professor Marcel, please, the
Thank
time
you,
is yours.
Dr. Firly, our master ceremony. Good day. Assalamualaikum warahmatullahi wabarakatuh. Shalom.
Waalaikumsalam warahmatullahi wabarakatuh.
Swasti, Om Santi Santi, Om Namo Buddhaya. Good day, Your Excellency Professor Ari Pariansam, the President of Indonesian Society Endoscopy, Gastrointestinal Endoscopy Indonesia, and the Secretary General Dr. Kaka Renaldi, the President of Indonesian Society of Gastroenterology, Prof. Dadang Makmun, and Secretary General Dr. Ahmad Fauzi, and the advisor from Indonesian Society Gastrointestinal Endoscopy and the Society of Gastroenterology, Professor Dr. Abdul Aziz Rani, and our honorable faculty in GIGAS 2020-2021, Prof. Rai Sutekno and Prof. Ronnie Fast from United States of America, and Prof. Jong Hamun, South Korea, and Prof. Mohan Ramchandani from India, and our faculty from Indonesia, Prof. Aziz Rani, Prof. Dadang Makmun, Prof. Murdani, Prof. Dr. Andri, Prof. Iswanusi, Prof. Naris Zubir, and other experts, and also the participants of the GIGAS 2020-21, and also the sponsor of GIGAS 2020-21. On behalf of the organizing committee of GIGAS 2020-2021, I would say thank you very much for your participation of all the faculties, all the speakers, and all the participants, and all the sponsors which already participate in this GIGAS 2020-2021. As you know that this GIGAS is or delayed from 2020 to this month because of the pandemic COVID-19. But we have already make this program successful in this 3 weeks era, and we have already done 6 plenary lectures, 10 symposiums, 1 dry workshop endoscopy program, and 1 meet the expert panel discussion program successfully with virtual program. And the participants of this GIGAS 2020-21 is is 296 participants and include 176 specialists and 120 general practitioners. We will thank you. We thank you all the sponsor which already participate in this GGES 2020-21, and the sponsor platinum. I will say to Dr. PT Takeda and PT Daria Varia and PT Meiji, and also we have sponsor, gold sponsor, Abbott, AstraZeneca, Dexamedica, Megalife, Esai, Guardian, Kalbe, and the others. Yeah, and also we have silver sponsor PT Nanjang International. This GGES, Jakarta International Gastroenterology Endoscopium and Dry Workshop Endoscopy, is done successfully with virtual program in this year, and the discussion went well, and all of the participants say that it is very good program. Also, there is a limitation because we cannot do the live endoscopy workshop in this GGES 2020-21. So we hope this GGES will continue, will be done continuously, and then can be done good. And then also we have pandemic COVID-19, but maybe we can do it again in 2000 at the end of this year, 2021. And this endoscopy gastroenteral is must be developed continuously for our Indonesian people. Also, we have there is a lot of limitation, and we have to be careful because if not, our doctor and our nurse will have the COVID-19 infection. So at last, I will stop. I will close this GGES 2020-21, and I officially close this GGES. And then thank you very much for the participation and for your attention. And we see you in GGES at the end of this year again, the GGES 2021 in this year. Thank you very much for participation and attention. Thank you, Dr. Firly.
Thank you very much, Professor Marcellus Simadibrata, for the closing remarks. And now, for all participants, please turn on your camera because we are going to take a photo together. And also, we are going to take the several photos. So please stay still. Okay, please, for other participants that hasn't been open or off or turn on your camera, please turn on your camera. Okay, the committee, are you ready? So, okay, I will count 1, 2, 3. Once more, 1, 2, 3. Maybe once more, 1, 2, 3. Okay, thank you very much. And finally, this is the end of the virtual Congress today. But before that, we would like to ask all participants to fill in our event survey. Kindly go to this following link. Make sure you pay attention to the capital letters. Please fill in the survey form. Your voice is so meaningful for us. You can also find out the link at our platform auditorium, chat column, or scientific program. Okay, thank you for joining with us. Hope this Congress will be very useful for all of us. See you in the next virtual Jakarta International GI Endoscopy Symposium. Stay safe and stay healthy, everyone. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Fredly.
Thank you, Professor Marcel. Thank you for all committee. Thank you for all participants.